Why did you name your account Spinach in the first place?
Oh, it's I mean, I do not change it.
All
So
right, all
yeah,
right.
so I
Okay,
have a
okay.
YouTube channel from like where I have named my account as Dr. Spinach.
All
So
right, all right.
and it comes from there itself. Yeah.
All right, all right.
Yep. What I'll do is I'll start sharing my screen. And see, I'm also in my learning phase, so I wouldn't say that I know everything. So in case you
It's
feel like,
perfectly all right.
yeah. So
Okay,
I made
so
like a small PDF for that can help us with like having a
how did
overall
you manage
idea
making
of.
this? Did you use some software or?
So yes, I'm yeah. I Can you see my screen fully?
Yeah, 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 yeah. I'm seeing it. Yeah, I can see it.
Okay. Yes, I
Okay, this
am
is
using
schizophrenia.
Samsung. Yes, yes. So I'm using Samsung Notes actually.
All right.
Yeah, I have created this PDF on Samsung Notes. And are you able to see? Can you just tell me, like, on your screen, is it like, are you able to see the whole thing on your full screen, or is it like vertical and then half of the screen is empty?
It's basically covering half of the image, basically, not the full image. Uh, for a moment, yeah, it was the whole of the image, but yes,
Okay, so is it full of image now? Now is it fine?
yeah, it's the full image. Yeah, this
Okay,
way we
okay.
can see the. Yeah, yeah.
Yeah, yeah, all right. Yeah, I mean that was in the landscape and portrait
So I
mode. That
can use my screen to maximize it, zoom in and zoom out. But yeah, it's perfect right now. Okay, so
okay.
let me tell you what I'm seeing right now. The screen you're showing. It's
Mm-hmm.
basically showing global epidemiology from any mental disorder to eating disorders. And
Yes, yes,
okay, so that's fine. Yeah. Okay.
it's correct. All right, all right. So I'll just show you like what we can go on and study for today. Is we'll start with the epidemiology of schizophrenia. Actually risk factors should come at the end, but we'll look into the risk factors there itself with the epidemiology. We'll also
Okay.
discuss epidemiological data from England. And then we can go on to ICD-11 criteria of schizophrenia.
All
Um,
right.
Next, we will be discussing about history of schizophrenia. What are the important contributions from different?
Why don't we start? Why don't we start with the history?
Yeah, we can start. Let's start with the epidemiology, and then let's come to the history.
All right. All right. All right.
Right.
No
Okay.
worries.
Okay, cool. So, global epidemiology, any mental disorder according to WHO, we have, can you, like, okay, according to WHO, this is the 2022 report from WHO. Any mental disorder, we have 13% of all ages. This is important. And then
Oh, yeah. This is
coming
more
to
important.
yes, coming to schizophrenia, because we are discussing about schizophrenia, we only have 0.3% of people who are affected by schizophrenia, right? So
Point
this
three.
is, yes, that's it, point three. Now, when we come to epidemiological data from, when we are looking at the England and globally, like this is something I've taken from MRCpsych preparation, like
Okay.
specifically from there. So we have two things here. We have one is annual prevalence, and the other one is lifetime prevalence.
All right.
So whenever we are talking, yeah, and we are going to divide this into psychotic disorders and schizophrenia. So psychotic
Okay.
disorders um, is going to include schizophrenia as well as the other other disorders which have psychotic symptoms. For example, even
Okay.
when we talk about ATPD, acute and transient psychotic disorder, when we talk about even depression leading to psychotic disorders. So any psychotic disorder is different from
Uh-huh.
schizophrenia, is included. You got my point, right?
Okay. Okay. Okay.
So we have psychotic disorders and annual prevalence. In England, when we talk about annual prevalence of psychotic disorders is 0.4%. This is according to the
That's
study or
right.
data published by Kirkbride 2012. And
All right.
globally, we have what we have already seen. From WHO, it is zero point 0.3. and well, by
Yeah, it's
Simeon.
almost the same. Yeah.
Yes. And when we come to the lifetime prevalence, we are talking about global lifetime prevalence here for psychotic
All right.
disorder. Um, Now, we have divided this into all causes and only schizophrenia or schizoaffective causes. So,
All
all
right.
causes of psychotic disorders, as we said, this will include even substance use disorder. So, any
Okay.
alcohol induced psychosis will also come under this. For example,
Okay.
right? So, we have 3 to 3.5% of total prevalence of psychotic disorder according to McGrath 2015. Similarly,
Okay.
and when we talk about under this, McManus 2014 articles says that only the schizophrenia, schizoaffective, or persistent delusional disorders comprise of 1
It's
to
only
1.5.
1.5%. But
Sorry?
I have a suggestion. I have a suggestion as to use the last slide instead of this, because the data furnished here is of around 10 years back at least. And the
Yeah,
previous slide basically showed data from around 2 years back. So that
yeah,
being the
that's
latest
correct.
one, I think
Yeah,
we need to prefer using that instead of dividing ourselves into two. Our minds, it'll be just dividing our mind into two. So we
I
need to
agree.
use this double epidemiology table instead of using the next one.
No,
This
I
being
do
the
agree to that. Yeah, yeah, yeah. I do agree. But if we, okay, so for example, but they don't have given, they have not given like separately for psychotic disorders.
all right, yeah.
So,
So the division is lacking. Yeah, the distribution
so
is lacking. So
yeah.
let's refer to the second one. Okay,
So just
then it's
so
all right.
in case they ask questions pertaining to only psychotic
Yeah,
disorders, then let's go with 3 to
all
3.5%.
right,
If they
all
ask
right.
for schizophrenia, no, we'll just go for 0.3% for schizophrenia. And for psychotic experience, now psychotic experience is um, different from the disorder itself. So it is just a brief experience, a brief episode, which is not meeting any diagnostic threshold. So people who experienced the psychotic experience accounted for about 5.8% in total. All right.
Yes.
So we have globally, we have if we go like if we it's 0.3% for psychotic disorders. Even for schizophrenia, it is 0.3% nearly. And when we go to psychotic experience, it is 5.8%. Uh,
Okay.
okay, wait, we are sorry,
Five
I'm so
point
sorry. We
eight.
have annual prevalence and lifetime prevalence. There's a difference between that. So yeah.
Yeah.
So
Okay.
what the
Psychotic
question
experience.
depending, yeah, upon the question, lifetime or
Okay.
annual prevalence. Okay. So
Lifetime prevalence of 5.8% according to Megra 2015.
yes, it is
Do you
psychotic
know
experience.
how am I going to remember this?
How are you going to remember
Yeah,
it?
it will be through Megra, the baller. Megra 2015. Being a cricket fan, I can remember and relate it to Megra, the baller.
Oh, okay.
Yeah, so,
Okay.
yeah,
I'm not
we need to have
I'm
some excuses to remember things.
okay, great. Great. I mean I don't know
Okay,
who that
so
guy is, but
uh,
yes.
let's move on. I think we can move on right now.
Yeah, yeah. I mean, this is something that we just need to remember so we can do it on our
Yeah.
own. Yeah. So we have incidence rate. So we were looking at prevalence rate now. We go on to seeing the incidence rate. Incidence rate of I'm sorry. Incidence rate of non-affective psychosis. In England,
Non-effective. Okay.
non-affective is same as this one. All of these are comprised of non-affective. Anything?
15.2 per 100,000 years.
Yeah, this is what was given in the text. Like from where I took this, from that,
Oh,
like, yeah,
okay.
yeah. And globally, it is 0.2 per thousand per year, according to Messias, 2007. It's just to, mug up. That's it, nothing else.
Yes, yes.
Yeah. Now let's, as you said, we can go on to the history first, and then we can, yeah.
Okay, so it starts from
from
Who
Emil
is it?
Kraepelin.
Who is this? Kreplin?
Kraepelin, yes.
Yeah. Okay, Kreplin.
Yeah. So this is the guy who, well, who first termed psychosis, who divided psychosis for the first time um, into organic psychosis. I'm sorry, organic psychosis and other broad spectrum psychosis. So, what happened with him was he found that there is a psychosis that is caused by syphilis or any other organic cause. So he understood that okay, there's a difference between an organic cause of psychosis, and there's a difference between any other cause that is not because of organic causes. So and then
Okay.
other in the other psychosis, he divided them into primary psychotic disorders, into manic depressive psychosis and dementia precox. So, so we have this kind of organic psychosis. Then we have broad group of psychosis, and organic psychosis we have syphilic insanity and general paralysis. In broad group of psychosis we have two, that is manic depressive psychosis and dementia precox. Now he
Yep.
said, yeah, as far as I remember, please look into this. He said that these two, well,
Yeah.
manic depressive psychosis and dementia precox. Um, um, I exactly don't remember, so I'm not going to say this. As far because I think I read that dichotomy means that um, that they occur in episodes. Like, for example, manic depressive psychosis. So there will be an
Uh-huh.
episode of mania and then there is an episode of depression. So there is a dichotomy in the primary psychotic disorders. And actually, when we went on to understand what he was trying to say was that we actually found out that dementia precox was well, slowly we understood that it is schizophrenia, and manic depressive
Okay,
psychosis
so
were
it basically
mo-
referred to what went on to be known as schizophrenia.
yes, right.
Okay.
And this went on to be known as mood, which came under mood disorders. Then it got divided into
All right.
depression, bipolar, something like that. So yeah, the next one is Eugene Bleuler. So Eugene Bleuler is very
This
much,
is the person most often mentioned in questions when preparing for master psych. Like I have seen him being mentioned quite a few times. So what is
yeah,
his contribution? Okay, so schizophrenia was basically the
termed.
term that he introduced. Okay, okay,
Yeah. Yeah, and then he also gave the four A's of schizophrenia, which were like more or less, which we now understand. Well, so these four A's include autistic behavior and thinking, abnormal association, abnormal affect, and ambivalence. Now, when we go on to see autistic behavior and thinking, someone who is behaving or thinking in an autistic manner, that means they are socially withdrawn. They have a little bit of different way of thinking. So that is why he gave this name. Then abnormal
uh-huh.
association. When we talk to the patients of schizophrenia, we usually see that they have a loosening of association. They'll speak something and then they will connect it to something else which has no actual connection.
Yep.
They have they have abnormal associations. This is like the way I have remembered. And then we have
Okay.
abnormal affect. So of course, in schizophrenia, patients have flat or blunt affect. They don't actually have the expressions,
As,
emotional expressions
as
that we
we
see.
expect from normal people. Okay.
Yeah. And then
Ambivalence. What does he mean by ambivalence?
ambivalence means, well, for example, if they are in a situation in it where they should mourn on a death of a person, but well, they have this kind of emotion. They have a contradictory feeling there, like they won't mourn, they will start laughing, for example. And there's another meaning that was told by ambivalence was they have this two things at the same time. For example, I'm thinking that you're a good person, but at the same time I have this feeling that you're a bad person, you're not a good person. So
Okay.
at
So
one
it's
point they will,
basically the contradictory thinking that they have.
yes, yes, so at one point they will be very good to you, they will think you're a good person. At another point they will start behaving very irrationally. They will start fighting or getting irritable, so verbal physical aggression. So this
Well,
kind of
do we need to
ambivalence.
remember the years that these people were relevant? Like case of Bruller, do we need to remember when did he identify the term schizophrenia? Or in case of Kent Snyder, do we need to remember the years that he sort of spoken
We
talk
don't
about?
think so. No. Well, these are definitely as far as the mid 20th, mid 19th century. Sorry, they're around mid 19th century. All of these people, but I don't think we will be asked the years because MRCpsych doesn't actually
Yeah,
want.
because this is not important enough to be asked in the exam.
Yes, yeah, but the names are important. For example, who termed schizophrenia? Very
Yeah,
simple
names are
question.
important. More importantly, yeah.
Yeah, and
So
then
let's move on to Kent Snyder.
Kurt Snyder, yeah. So this is Kurt Snyder,
Kurt
and
Snyder.
he
Okay.
is very much known for the first rank symptoms. So whenever we are on the rounds or we are in the OPD, the first thing that, because now first rank symptoms are not very relevant, but because they have been going on, so they usually ask, are all the first rank symptoms present? So what are the first rank symptoms that are present in this patient? So whenever we are presenting something, so this is a very frequent question that is asked because we have the old consultants, right? So that's why these are important.
Yeah, the
FRS
senior
are the,
consultants do tend to ask these things.
yeah, yeah, that's right.
Yes, yes.
So we have total of
And if you
11
don't know,
first.
if you don't know, you cannot claim it to be some sort of, you cannot call it something obsolete in front of a senior consultant because for them it's
No,
still relevant,
yes, yes, that's correct. And for them, it's also, even for us, it is
more important.
his- history, right? Yeah.
They may judge you on they may judge you in your part two or in your exit exam and basis of these things, and on the basis of not remembering them.
Yeah, yeah, that's
Yes,
true. It's
the
true.
sad part.
Okay. So we have, you see, we have three time. This is something that you might also be familiar with. That is, we have thought phenomena. This is how you can remember it: thought phenomena, made phenomena, auditory hallucinations, and then we have delusional perception and somatic passivity. So, thought phenomena, under which we have thought insertion. Yeah, I mean,
Thought
you must
withdrawal.
be knowing it already. What does these means? Do we have to like go on to
We need to just mention them, not to sort of elaborate them because we're already studying about these things.
all right. So next we have thought insertion, withdrawal, and broadcasting. So this comes under thought phenomena. We have made
All right.
phenomena, which is in present status examination. So this is an old state examination. Usually used to call made phenomena is present or not, but in the present state examination, we call these delusion of control. So all of these three things come under delusion of control. So do you have made feelings, made
Okay. All
impulses,
right.
or
Correct.
made
Made
volition?
feeling, made impulses, and volitional acts of choices. Volitional
Yeah,
acts. Yeah, volitional acts.
yeah, volitional
Okay.
acts, right? So
So
something that
what does this volitional means?
um
Do we have some meaning for this? Because I'm
I
not clear about them.
so what does volitional acts means is that a person's actions are um, controlled by an external agent, and the person feels that he's just a passive participant in the action. So
Okay. So
if I am taking that, if I'm let's say holding a water bottle, or if I am taking my hands above my shoulder, whatever it is that I'm doing, this is not done by me. Someone else, some external agency, someone else is doing this to me. And when
okay.
you
So
ask them, yeah, please.
means like somebody's made to do something against his will, or not even
Ye-
involving his will.
Yes,
All right. Okay, let's move on to
we
auditory
have,
hallucinations.
yes. So we have auditory thoughts, voice commenting, and voices arguing or discussing. So this is thought echo, which we say first person. This is voice commenting is, well, second person, which we call second person auditory hallucinations, right, in present state examination. And voices arguing or discussing is third person auditory hallucinations. So,
All right.
very,
And this
very,
is something very important for me at least to remember this. Like voices commenting is a second person, voice like arguing or discussing is a third person. All right.
yeah.
Okay.
So just think of it like a first. So this is like an English terminology that they have used: first,
First,
second, and
second, and
third
third.
person.
It
So
basically to make it easier. Yeah. Okay.
yes. So if someone, if they can, if someone is commenting, so it's like the patient and the voices are actually talking. Voice is talking to the
Okay.
patient. Voice is talking about the patient to the patient. Is voice is second person.
It makes it secondary or second person,
Yes.
and
So
people talking among themselves about the patient is a third person.
exactly. That's correct.
Okay.
Okay. Next, we have delusional perception. Okay, do you know what this is? I would like you to, or if you don't, let's just take a
No,
guess.
we can yeah, delusional perception is basically a perceptual disorder when
Mm-hmm.
our thinking makes us believe in something that is not true.
Yeah,
And okay, so
yeah,
can
you're
we
right.
should we elaborate this further, or do we need to just skip it?
We can just skip it. Like, I will just like, I'll just say one line to this so that it is easier to understand. So I have a perception in my mind that, um, um, well, this is very simple. Like, I have a perception in my mind that this pen how I don't know how how to put it this, like, delusional perception is like my perception which is actually delusional and not true. So if that neighbor is trying to harm me, is my perception, but it is not true, so that is why it is delusional
Yes.
perception. Yeah.
Despite me being counseled or me being told that this is not true, I'll still keep up with my belief, and I'll not be shying away from my belief. But this will
Yes,
be my delusion. Yeah. Okay.
correct. So now we have somatic passivity. Somatic
This is something
passivity.
I don't know an inch of.
Okay, so very in very simple terms, so this in this case, in this an example would be that something is crawling on my skin and someone has done that to me. So
Okay, so this
it's
is
like
something new for me.
yeah, somatic is somatic passivity. So it is like it is related to the senses. Somatic is related to senses. It
Okay.
could be tactile hallucinations. It could be visceral hallucinations like any pain or something that that someone has done to them. And passivity, I'm a passive what do you say? Like passive recipient of this
Okay, so
thing.
I'm just a recipient, a helpless recipient.
Yeah. So, and plus, it is very important that there is an external agency that is involved here. Again, this is not something like this is something that has been imposed onto me. Like these are like I can feel something crawling on my skin, or I have this pain, and this has been imposed onto me by someone else or something else.
Okay.
Hmm. So that is somatic passivity.
What is this SFRS?
This is like Schneider's first rank symptoms. So,
Okay.
what's important for us to know is that they are not pathognomic, that is, they are not the hallmark of schizophrenia. So, this question usually comes like, are they the hallmark of schizophrenia? Like, in true or false? Like, we have like a question in MRCpsych where they will write that all of the following are true except. So, it is not true that SFRs are hallmark of schizophrenia. They are not hallmark. They are not pathognomic of schizophrenia because
Okay.
all of these symptoms these things can also be present in any other psychotic disorder.
So they are
So, for
not
example,
basically specific. They may
yes,
be sensitive findings, but not specific.
yes.
Okay.
So this is like the thing, and then we have there is more to the history. That is this one classification and types. This is again a little bit of history.
Type 1 and type 2 schizophrenia.
Sorry. Yeah.
So what is this type 1 and type 2?
So initially, when DSM or ICD didn't come up, we had some of the authors who found out, who were like digging into what is like doing a real research here.
Okay.
And Timothy John Crow was one of them who actually termed the type 1 and type 2 schizophrenia. and he's also one who actually did this. It's a very big study that is done on schizophrenia at Northwick
Northwick
Course.
Park Hospital.
Yeah, it's in Harlow, London. I might be sleeping
Okay.
when I was reading, so that's why my this is my handwriting. So
Right. Yeah.
is what he did is well, he did three things. He divided them here. So he did CT scans, brain CT scans of people with schizophrenia. He also used the drug, and the drug was this one, flupentixol, and he tested them on patients of schizophrenia. This is an antipsychotic drug, and and he also saw the
Okay.
mortem findings in the brain of the schizophrenia patients. So very relevant study. So let's go on to a little bit, like, in order to remember what he found. So on CT scan at, sorry, Northwick Park Hospital, it's not Park, it's Park. I'm so sorry. He did this study between
Okay.
74 to 78.
Yeah, this is something I do confused. I got confused about. This is Northwick Park Hospital. Okay.
Yeah, it's Park. I'm
Around
sorry.
50 years ago, it was. Yeah, it is around 50 years ago. Okay.
Okay. Yeah. Yeah. So what he did was, well, he saw the brain scans of these patients who were admitted and who were having symptoms, schizophrenic symptoms. So he saw that they had increased ventricular size, well, in
Yeah.
patients of schizophrenia. And he also saw that people with increased ventricular size, patients, had more negative symptoms.
All
And it
right.
is, yeah, and it is also important for us to understand that these negative symptoms were not explained by any physical
All
treatment.
right.
And that means, like, it is not that they had any other brain injury or brain or illness or any other physical treatment that they might have taken for the same, like any
Okay.
treatment, even a drug treatment. We're not even talking about that. So that is what he found.
All right.
This
So,
this proceeding.
and on the contrary, can we generalize like having a decreased ventricular size to be associated with positive symptoms?
Yes, we can. Actually, in neurobiology, when we are going to study there, it was actually found even now that they have decreased ventricular size.
All
Sorry,
right.
not decreased. Sorry, it is increased ventricular size, which actually decreases the cortical size of the brain.
So, if we have increased ventricular size in
Yeah.
patients with negative symptoms, can we have something that is on the contrary, that is decreased ventricular size in case of positive symptoms?
No. We can't say that.
It's
No,
not generalizable. Okay, okay,
no,
okay,
no, 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 no. So
okay.
decreased ventricular size
It
is
must
related
be
to
it must
nothing.
be a stupid question of me, but yeah, it's not an stable way to learn about things.
Yeah. So we just have to remember this thing in context of this person. So, and definitely in context of neurobiology, when we are going to see, like, further, it was actually found that in patients with schizophrenia, in neurobiologically, their ventricular size slowly increases. That means their
So,
cortex is decreasing, and that is what is leading to a lot of symptoms. So we have
okay,
cognitive issues with schizophrenia as well. So this is true, but again, because, and this is what he found as well, Timothy J. Crow. But it, just remember it about the negative symptoms. Please just remember it in context of him, because this is not written somewhere else that negative symptoms are more in patients with increased ventricular
okay.
size. We
So,
did not find that, but he found that. So that is why
all
it is
right,
important,
all
right?
right, all right.
Yeah. Then what he did was he gave a first generation antipsychotic um, to these patients, and he tried to understand, like, what these did. So this first generation antipsychotic, that is flupentixol, is a dopamine D2 blocker, dopamine 2 D2 receptor blocker, and he found that patients who had, like, it actually reduced the positive symptoms in patients of schizophrenia, but it has minimal improvement in negative symptoms of schizophrenia. So this was also a very, very
This is basically for D2.
sorry, yes, D2 blocker.
Yeah. Okay.
Yeah. So this was also a very significant finding because even today, so whenever we are in the clinics, and we do usually use second generation antipsychotics, but we all know that if positive symptoms are not improving, that is hallucinations or delusions, even with second generation antipsychotics, we prefer giving one first generation antipsychotic or adding first generation antipsychotic because first generation antipsychotics are actually known for reducing the positive symptoms in patients of schizophrenia.
Yeah,
So
I
this
do
was a
have a personal experience of injecting patients with this
super
fluenzol.
oh
Yeah.
wonderful. Yeah. Okay. So the next one is the post-mortem thing that he did. So what he did was he took the brain slices of these patients and he assessed them using homovenilic acid. And there is one more, H. Spiron.
How many minutes are we left with in the meeting?
Sorry, what?
How many minutes are we left with in the meeting?
No, I have this pro version. Don't worry.
Okay. So we can, stretch for as long as we
Oh,
want.
there is. Sorry, there was one more person who was there. I don't know whether. Oh God, I because I'm sharing my screen, so I could not see that. Adil, you have already joined. I'm so sorry. We are like done with one fourth part of the uh of the
Okay.
presentation.
How many people are there in the meeting?
You and one other.
All right. So let's have a look. Who is the other person? How can we see that?
Adil, can you hear us?
Good evening.
Good
So
evening.
Miles
Hi.
has joined. Well.
I'm sorry. Great. So we are already like done with one fourth of the part. I hope you can join for the rest of it.
Okay, so
Yes,
Dr.
okay.
Adil is
Yes,
here.
thank you.
Sure. All right. So, sorry, am I sharing my screen? Because yes, I
Yes.
guess I am, but I can't see it myself. Let me just share it
So we
again.
were discussing the post-mortem findings.
Yes, that's right. Share specific app. So we were discussing the postmortem finding that was given by that was done by Timothy J. Crow. That is Timothy John Crow. We are actually discussing the history of schizophrenia. As of now, we have already done discussing with epidemiology of schizophrenia and half of the history as well. So yeah. So he did three things. That is, he did CT brain scans, he injected a drug, and he also, checked on the postmortem findings of these patients. So what he found was, he assessed, what he found was, so what he did was he tried to assess dopamine. So we have dopamine. Dopamine was assessed using was kind of like homovalenic acid. So he used this dye to check how much dopamine is in the brain, and he used H-spironone binding, this one, to check how many dopamine receptors are there. So if you can see, it is written here. Dopamine turnover was assessed by homovanillic acid or dihydroxyphenyl phenyl acetic acid concentrations. And D2 dopamine receptors were assessed by H-spironone binding. So what he found was dopamine was not increased, but number of D2 receptors were increased, and he also delineated the areas where he found them significantly increased. He did not. No, he did not. So he said that uh, wherever the dopamine receptors were increased, it was related to positive symptoms and not with negative symptoms. So people with having more H-spironone binding, he also correlated them with having more positive symptoms. And this led to the finding that the symptoms in schizophrenia suggested that dopamine in schizophrenic patients um, is increased, which leads to upregulation of receptors. Now, there is a big limitation to that. Let me just explain it this way. And that is, I don't know, Shahid, did you get like what we are discussing here?
Well, I skipped a part of the discussion.
Oh, you
Let
did?
me have a read. So, dopamine turnover, uh, like passed by, assessed by homovenilic acid or
Yeah.
dihydroxyphenylacetic
Phenyl
acid
acetic acid. Yes,
concentration
that's
was
correct.
not increased. Numbers of D2 dopamine receptors assessed as H-spiridone binding were increased. Okay.
Yeah. And it was also
The number
said
of
that,
D2
so,
receptors in postmortem brain was found significantly related to positive but not negative symptoms assessed in life. So basically,
yes,
they want to say what they want to say is the number of D2 receptors were more likely related directly to the positive symptoms, but not to the negative symptoms.
yes, that's correct. But now,
Personally speaking, why was it so?
no, so the thing is that is the limitation of this study. So the thing is, like in actual, what happens is we have more dopamine in mesolimbic system, that is in striatum. We are going to see this in the neurobiology of schizophrenia. So it is not that we have less dopamine. So there's one things that was wrong, um, wrongly addressed. So he said that dopamine is decreased, but dopamine receptors are increased, right? So it could be anything.
So this was
But
basically misrepresented. Sort
yeah,
of, this is the limitation for this study.
yes, yes. But the thing is, this was important for us because at least we now knew that there is something to do with dopamine here and dopamine receptors, which was not discovered before. So this was still a very
This
important
was
study.
this was still more important. Yeah.
Yeah. So even if the findings were not correct, or for whatever reasons, because he also took the brain scans, or sorry, brain postmortem slices of the patients who were already on antipsychotic medications. So there are a lot of things that change with antipsychotic medications. They were not the like uh, the newbie breeds of of people who had schizophrenia, like without any treatment. So this changes a lot of things. So yeah, so these are the three things that Timothy John Crow actually gave us, and then he divided these schizophrenia into two syndromes at the time, between the 1970s at that time, 78, 74 to 78. So what he did was he said that there are two types of schizophrenia, which is type 1 and type 2. And he described, so anything that is having, you see, the positive symptoms is corresponding to type 1, and anything that is having the negative symptoms is corresponding to type 2. And there is one more thing which we found, that what he divided was not wrong, but it was in a spectrum. It is not that there are two types of people in schizophrenia, type 1 and type 2, but initially, in acute setting, they usually have the positive symptoms, usually, it could be negative as well, which then slowly deteriorates to having negative symptoms. So it is not type 1, type 2 separate, but actually it is a spectrum of a disease which actually progresses from type 1 to
And
type
this
2.
is what we know right now. This
We
is
know right
basically a
now.
spectrum, a
Yes,
continuum of
exactly.
symptoms, not just groupings.
Yes, right. But still, what he did was like a big thing. So, but what he said that we have characteristic symptoms in type 1, hallucinations, delusion, all positive symptoms. In type 2, we have affective flattening, poverty of speech, loss of drive, what we say evolution, and negative effect. And then type of illness is acute, and this is chronic. Response to neuroleptics is good. Of course, it will be when you're treating a fresh case of schizophrenia. It will be, but if it is a long-standing case of schizophrenia and untreated psychosis, then there will be poor prognosis even on the antipsychotic medications. Then we have outcome. Type 1 is reversible. Type 2 is, we don't know. He said question mark irreversible because, of course, the cognitive symptoms usually are irreversible in these patients because in long term there is change on the cellular level. That's why. So on the brain level.
We may partially
Then
agree to this.
yeah. So okay, so that is it. Now, going on from here to the next one, that is Liddle syndrome. Now, this is more of a well, he was more he gave more about the neurobiology aspect of the disease, and it's more of like we do have to learn because it's not something that not very I don't know how to say that, but it's not very
Not very
relatable.
much
Like
relevant right now.
yeah. Yeah, mostly you have to learn this. So, what Little did was he found that there are pattern of symptoms in schizophrenia, and he separated them into three distinguishable syndromes. The first one was psychomotor poverty syndrome, disorganization syndrome, and reality distortion syndrome. So, psychomotor poverty syndrome is with a decreased PMR, that is, decreased speech, decreased affect, and decreased movement. Psychomotor activity was decreased, or psychomotor retardation, you can say, which we say there is less movement and there is less speech, and the effect is flattened. Then he said there is disorganization syndrome, which is disorganization of behavior and speech, or you can say form of thought and inappropriate effect. And he said the third one was reality distortion syndrome, where he actually focused on the positive symptoms. So at that time, everyone wanted to give their own distinguishable forms of a disorder. So that is why Little also came up with the same. And well, the most important contribution of Little was actually doing this PET scan studies, which found a few more things that were relevant that are relevant right now as well. So um, well, he showed that each of these three syndromes, so he divided these syndromes according to the PET study, that according to specific pattern of perfusion. The first one was psychomotor poverty syndrome. He found that there is hypoperfusion of the left dorso-prefrontal cortex. This much is enough, and it extends to medial prefrontal cortex and anterior cingulate cortex. So whenever we are going to see the neurobiology, then it will be even better, even easier to understand all of this because I mean it's more to mug up rather than to understand here. So left dorso prefrontal cortex, he actually like prefrontal cortex, and we have anterior cingulate cortex. That is what he said are associated with these things: decrease in movement, speech, and affect. So psychomotor retardation. And coming on to disorganization syndrome, that is disorganization of speech and behavior, that is the disorganized way of behaving and speaking. He said there is hypoperfusion in right ventral prefrontal cortex and anterior cingulate cortex, left dorsal and right ventral, and dorsomedial thalamic nuclei. Little to mug up. Moving on, we have reality distortion syndrome with delusions and hallucinations. He said there is increased activity, not hypoperfusion. This time there is increased activity in left parahippocampal region and left striatum, that is basal ganglia. So hippocampus and basal ganglia is involved in delusions and hallucination. Later on, when we are going to see the neurobiology of the same, we will actually see that basal ganglia, that is striatum, is involved in positive symptoms of schizophrenia. And for the rest, these are very mixed up. Like it is not exactly that. So we have like cognitive symptoms, we will see what is involved in cognitive symptoms, which pathway is involved in that. But these rather are a little mix up of things. So just to mug up. Are like are you there? Is anyone here?
Yes, yes, I'm hearing. Yes.
Okay. Yeah. So you can so when we are going to see like in details in the neurobiology, you will find that dorsolateral prefrontal cortex in our brain is related with executive functions. So you can remember it this way that all the motor functions, well, executive brain functions, And so we have like the motor functions that are affected in the psychomotor poverty syndrome in the dorsolateral prefrontal cortex. So that is how you can remember it. And later on, we will also see that ventromedial prefrontal cortex is actually involved with emotions and social acts. So, and that is the behavior part, which is um, here in disorganization syndrome, ventromedial prefrontal cortex. Okay, this one is not important. Then we had deficit syndrome. We have deficit syndrome.
Which one is not important, Palak?
This one here, it's not important. It's like it's a little, well, it is kind of like a it is kind of like a these are the studies that are coming on.
No, but now the new studies, the neurodevelopmental hypothesis is trending now.
Yes, that's correct. But we, I think I have written this.
But it is in etiology, so we will study it there.
No, we have not studied neurodevelopmental hypothesis.
But it is a part of etiology. Now we are studying history.
I think I did not put it here, probably because I did put it here. I'm so sorry.
So, Dr. Palak, can you give me 2 minutes just the history, which I know a little bit? I studied it yesterday or a
Yes,
day.
sure, sure, sure.
Okay,
Yeah,
okay.
please.
So in his history, what I read was that Morel was the psychiatrist who used the term dementia precox. He
Mm-hmm.
said that this illness is basically a dementing process. Okay, it was in 18th century. After that, there was another psychiatrist, German. His name was Kraepelin. So what Kraepelin
Um,
he did?
yeah, we actually discussed that when you were like not
Okay,
here. Yeah, we have
okay,
discussed that here completely. So
okay.
we have
Have we
discussed
discussed
Kreplin, Bleuler, Kurt Schneider, and
Okay, have we discussed the 4 A's of Bleuler?
yes, we have already discussed that. So we have like four
Okay.
A's of Bleuler. We have already discussed that part as well.
Schneider.
Yeah, we have discussed first rank symptoms, like
Okay, that's great. That's fine. Yeah.
completely.
Okay.
Yeah, yeah. Is there something else that you wanted to mention?
Can you repeat the for within a minute the first rank symptoms
Yeah,
just for
sure.
my
So we have
understanding? Yeah.
Yeah, we have thought phenomena, we have made phenomena, and auditory hallucinations. Under thought phenomena, he gave three things: thought insertion, withdrawal, and broadcast. Under made phenomena, he gave made feelings, impulses, and volitional acts. And in the
Mhm.
present state examination, this made phenomena is synonymous to delusion of control. Then under auditory hallucinations, he said audible thoughts, voice commenting, and voices arguing and discussion. So this is thought echo, that is first person, and this is second person auditory hallucinations, which we now know, and these are third person auditory hallucinations, which we now know. Then we had delusional perception and somatic passivity.
So how many type of hallucination we have in first rank symptoms?
We have three types. First, so we have audible thoughts. That is, my thoughts are, I can hear my own thoughts, which we see in thought
Thought eco.
ego.
Thought
Yeah.
eco. Yes.
Yeah. Then we have voices commenting. That is second person auditory hallucinations. People are commenting or giving derogatory remarks to me. So that comes under voices commenting. Then we have voices arguing and discussing. That is third person. People are talking among themselves and talking bad about me. So these is third person auditory hallucinations. So we cover like 9 symptoms here. We have total 11. The 10th one is
Yes.
delusional perception, and 11th one is somatic passivity.
Okay. Thank you.
Yeah. Yeah. So this one I said not is not important because this is a little bit like even it went above my head as well when I was reading it. So I would not go into neurodevelopmental classification. Rather, what I have written here is something that we can actually go on to understand rather than using this table. So if we see congenital or neurodevelopmental hypothesis, it is early onset. So this guy here, Robin M. Murray, he said that we have congenital neurodevelopmental onset of schizophrenia, and adult onset of schizophrenia. Then we also have very late onset, but we'll just go into these two. He said that we have early onset of schizophrenia in congenital. There is early onset. Males are more prone than females. More negative symptoms are seen than positive symptoms. With what is MP? Wait a second. With minor physical anomaly and with minor physical anomalies seen and neurological soft signs of schizophrenia also seen in these patients. So so there are some what do you say, some neurological soft signs in schizophrenia, some minor physical anomalies which are not usually um, you know like which we don't usually give thought to. So these could be, for example, um, coarse hair or too much fine hair, increased distance between the inner corners of the eye, or there is an extra skin upper like epicanthus fold on the eyelid, or low set ears. You have clinodactyly, that is curved fifth finger. So I don't know whether this is important. I don't think that is much important, but definitely for us, like in cases of like we read these neurological soft signs because in MD psychiatry examination, we are asked about this. So these are like the signs. Do you know what are these? Like what are neurological soft signs actually? Other?
So So basically, these are those signs which are not present in a normal person. These are some neurological findings which we can see in a patient which are more prone to schizophrenia later in life. It is a part of neurodevelopmental
Yes.
hypothesis which says that there is some trauma to the brain at antenatal period, and the symptoms started later on when the person become adolescent, like at that time.
Yeah. Yeah, and then we can actually, if we were aware enough, we could actually see these neurological soft signs. That's you're right.
Yeah.
Yeah. So he says that this has a poorer outcome and continuous course. And then we have adult onset. Yes, are you saying something? Do you want to? Okay, adult onset, typically late and more females than males, more positive symptoms than negative symptoms, and they have an affective component as well, that is mood component. Then they have
Okay.
better outcome and they have an episodic course. Then he said there's late onset schizophrenia, which is secondary to a neurodegenerative disease. For example, dementia leading to psychosis. So this
Okay.
is the way he divided schizophrenia into three. This was the neurodevelopmental classification given by Robin and Murray.
Okay.
Yeah. Then we have another one, deficit syndrome, which was given by eh, was deficit syndrome given by Little again? I don't remember. Strauss and Carpenter. This concept was given by Strauss and Carpenter. And what that they said the schedule for the deficit syndrome requires the presence of, sorry, two or more negative symptoms in a patient with schizophrenia. So at least two symptoms should have been present in the preceding year, and the symptoms are not better attributed to other symptoms of schizophrenia or to another psychiatric illness or to a medication effect. So they gave another schizophrenia. So other than schizophrenia, there is a schizophrenia deficit syndrome. So this is what these people gave. And they said that out of these six symptoms, there should at least be two symptoms in the past 1 year. And in order to remember what are these symptoms that are present in deficit syndrome, there is like, please read D3 comics. So we have P, that is poverty of speech. R, restricted affect. D, that is decreased emotional range. Three Ds, that is decreased, what is this? Interest and decreased sense of purpose.
Okay.
This is drive or interest. So, and then we have C for comic, that is curb. Okay, they have written curbing of interest again, anhedonia. So decreased drive and decreased interest is mentioned again. So we have restricted affect, diminished emotional range, poverty of speech, curbing of interest, diminished sense of purpose, and diminished social drive. So if any of the two are present for 1 year, this is a deficit syndrome.
Okay.
Yeah. Okay. Yeah, it's a lot of to remember actually.
Yeah, it's so much. Yeah, it's so much.
Yeah.
So, so do you remember the four A's? Can you repeat that in a
Yeah,
second?
sure. So let me just repeat it like this so that okay, I remember them. So we have first A is autistic behavior and thinking.
So, what does that mean?
That means that well, if you see patients with schizophrenia, they have a very different way of behaving and thinking, just like people with autism. For example, they are socially withdrawn, one example, and they have a very different way of thinking. So that is why Bleuler gave this term autistic behavior and thinking.
So, our professor used to tell us that what does it mean, and we didn't know, and then he answered that it doesn't mean that autism. It is basically a self-absorbed behavior. A patient of schizophrenia has his own thinking, thinking of and world of imagination. So this was that autism. Okay.
Yeah, the self-absorbed behavior. Wonderful.
Yeah.
Yeah, you can put
Yes.
it
Yeah.
that way.
Yeah. And other one other A, four A's.
This is
So
abnormal association.
so um, uh, loosening of association,
Yes, that's correct in our terms. Then we have
losing of association, autism, and then
abnormal effect.
um,
That's
blending of effect.
yes, that's correct.
Yes.
And
And
I forgot the last A. Association effect
ambivalence.
and ambivalence. Yes, ambitendency.
Yes.
Ambivalence,
Yes.
right.
Ambivalence. Yes.
So it's
So
like the
what
contradictory
what is
feelings.
yes, yes, ambivalence. Yeah.
So it's like I the person thinks that some one person is good, and then at the same time they have this feeling that no, they're bad people. So they have like a contradictory feeling about the things or about the
Yes.
people.
Yes. I'm just cutting your words. So in a book, the example is given that a patient of schizophrenia will stand at the middle of the door, and he will not decide that whether he should enter the room or left the room.
Yeah, so they are always confused in good in
Yeah.
yeah, in that terms you can say they're always confused.
Yes. Yeah. Right. Right.
Yeah, so these are the four ones we
Okay.
have already seen. Yeah. Here. Okay, let's move forward then.
Oh yes. Yeah.
1 second. I'll check if anyone is there.
So
No.
so Dr. Palak, so in Schneider first rank symptom, we have three types of hallucination. One is thought echo, the other one is a running commentary, and the third one is third person auditory hallucination. Am I right?
Yeah, you're right.
Oh,
Yeah, you're right. But we don't say thought echo. We say it audible thoughts. Like this is what he
okay,
gave. This is the term that he gave. Although in today's present state examination, the same thing is
okay,
called as thought echo.
okay. And other symptoms are passivity phenomena, thought insertion, withdrawal in broadcasting, and delusional perception.
Yeah,
Okay, great.
yeah. Okay, so we have a long lecture. So we'll just go
Okay,
on to understanding the neurobiology of schizophrenia now.
yeah, yeah, yes.
Yeah.
It's very important.
Yeah. So, well, neurobiology is focused on three parts of the brain, what that
Okay,
we have found. So this is striatum, frontal cortex, and temporal cortex. These three parts of the brain are affected in case of neurobiology, in case of schizophrenia, right?
okay.
So,
Mm-hmm.
um, I mean, we'll just see like what happens in striatum in the details later, but briefly, in striatum, increased dopamine and increased glutamate is happening. Then we have prefrontal cortex, where the same
No,
thing is
no.
decreasing.
So
Yeah.
you are saying you are telling me about the neuroanatomy, huh? Am I right?
Yes. Yes. This is neuroanatomy. So in neurobiology, we will be seeing into neuroinflammation. We'll be looking into oligodendrocytes, astrocytes, and reactive microglia. That is, these are the brain cells. Then we have gut
Okay.
microbe, mitochondrial damage, oxidative stress, um, hypothalamus pituitary axis dysfunction, and then we
No, no.
have this circuitry
In
dysfunction.
neuroanatomy, in neuroanatomy, which information is important in neuroanatomy?
We have temporal lobe, frontal lobe, and striatum. These three parts are important in case of schizophrenia. And what is happening here is
Mm-hmm.
in striatum, we have increase in glutamate and increase in dopamine. And similarly, just opposite to that, in prefrontal cortex,
Mm-hmm.
we have decrease in glutamate and
Mm-hmm.
decrease in dopamine and even decrease in GABA.
Mm-hmm. And what happens to these structure like cortex and temporal lobe and thalamus and striatum, their
Um,
sizes?
yeah. So what we see is we are going to see the neurological networks that are associated with it, and then we'll be able
Mm-hmm.
to understand what are the circuits that are involved, like what circuits are connecting them, and what is it happening to these circuits.
Mm-hmm.
All right. So we have, do you know like the four pathways that are involved in these in the neurobiology of schizophrenia?
Mm-hmm.
Can you name those
Okay.
four pathways?
So that mesolimbic system is
Yes.
important, and one other system is um, uh, that system which involved the cortex.
Hmm.
What is
Mesocortical system. Mesocortical.
meso mesocortical, and in which one part there is a which is associated with positive symptom, and other part is associated with negative symptoms.
Yeah, and then we have nigrostriatal pathway and tuberoinfundibular pathways are very important as well in cases of when we
Okay.
are giving antipsychotics and the side effects appear in cases of schizophrenic patients. So let us start with
Okay.
not the yeah. We'll see this later. We'll see the circuits here. So can you
Okay.
see my screen?
Yes.
Yeah, it's a little bit of okay. So we have the first circuit which starts from
Mm-hmm.
ventral tegmental area and
Mm-hmm.
goes to
Mm-hmm.
cortex.
Mm-hmm.
So this one here is mesocortical circuit, right?
Mesocortical. Okay.
Yeah. And then we have the one that is starting from midbrain, that is VTA, and going to nucleus accumbens. So this one here is mesolimbic. Mesolimbic. Then we have another one starting from substantia nigra, that is striatum, and then going into the substantia nigra and going into the striatum. This is nigrostriatal. This pathway here
Okay.
is nigrostriatal
Okay. This is a
because it
pathway which is important in that adverse effects due to
yes,
antipsychotics.
yes, that's correct. And then we have one other one that is starting from yeah, here. This is starting from tuberous process to infundibular
Infundibular.
process of yeah, pituitary gland. So this is
Oh,
tubero-infundibular pathway, right?
okay.
Now,
Yeah.
so
Okay.
these are the
Yeah.
four pathways, and now what is happening in these pathways is, well, in the first pathway, going from ventral tegmental area. So this is mesocortical pathway. In the mesocortical pathway, we have decrease in dopamine, and this decrease in dopamine is actually responsible for sorry for oh my god, why is my color not changing? Sorry, is actually responsible for negative symptoms of schizophrenia, and all the
Mesocortical.
yeah, and cognitive
Okay.
symptoms of schizophrenia.
Okay. So here the level of dopamine increased.
No, dopamine is decreased.
Oh, okay. Here it is
Okay, so
decreased.
I'll
Okay.
just repeat this again. So in mesocortical pathway, we have decrease in dopamine. In mesolimbic pathway, we have increase in dopamine. This increase in dopamine is actually responsible for hallucinations and delusions in patients of schizophrenia. So they are actually responsible for positive symptoms in schizophrenia. All right?
Okay. The meso limbic one.
Limbic pathway. So anything related with emotions, limbic system, this one is tips. And where we have dopamine increment, this is responsible for hallucinations and delusions. All right?
Okay. one is important for negative symptom, the other one is for positive symptoms. Simple as
Positive
that.
symptoms, right?
Oh,
So,
oh,
and even cognitive symptoms, because this pathway which goes to the cortex is actually helpful for executive functions of our brain.
okay. There's that.
So
Yeah.
when
Okay.
executive functions of the
Yeah.
brain are, yeah, less
Okay.
dopamine, cognition is deranged. Then
Good.
we have nigrostriatal pathway starting from substantia nigra to
Okay.
striatum. Now, this pathway is actually important for movement in general, right? So,
Okay.
when we block dopamine in this pathway, what happens is using the
Good.
antipsychotics, what happens is
It could be
APS.
Punyas. Hmm.
So this
Okay.
is what is happening here. Then we have the
Yeah.
last one, which is over here, from
Mm-hmm.
tuberous process to infundibulum. So tubero-infundibular pathway. Here, the dopamine actually levels prolactin. So if you decrease the dopamine or block the dopamine here, so prolactin inversely increases,
Okay.
invariably increase.
Glycouriamuria syndrome it causes, I think.
Yes, so this is leading to galactoria in patients of
Mm-hmm.
or amenorrhea in patients of
There's,
schizophrenia when they are on antipsychotics,
there's
right?
that. Yes. Yeah. Yeah. Yeah.
Yeah. So these are the four pathways that are important. Now, what is actually happening here is also important. So
Okay.
yeah, so what actually is happening that is leading to this mesocortical pathway decrease in dopamine and increase in dopamine? Let's just see. So
Okay.
yeah, you have to understand one thing that NMDA function is happening here. So in cases of um, NMDA receptors, these
Okay.
receptors are having dysfunction. So NMDA receptors are excitatory, let's say, if
Okay.
glutamate binds to them. So they are kind of excitatory receptors, right? So there is a
And it gives
dysfunction.
it's excitatory.
Yeah,
Okay.
one second. They once yes, they're excitatory.
And
They're
glutamate.
glutamate receptors. They are glutamate receptors, but if these receptors are present, if these receptors wait here are present on interneurons,
Okay.
so what will happen is, so if you see here, so this one is glutamate neuron, okay, and this one over here is interneuron. Then it comes here again. This is GABA interneuron.
GABA is opposite of glutamate, I think.
Yes, that's correct. So this one is glutamate neuron. This is GABA interneuron. And this one here is dopamine neuron. All right.
Okay.
Yeah. So now what we are going to do is see what is actually happening here. So glutamate is going to be released in the synapse. Okay. Generally, what will happen with the GABA interneuron, because this is a GABA interneuron, if glutamate is going to activate this GABA interneuron, then the signals are not going to be transferred normally,
Okay.
right? Normally, what will happen is this.
Mm-hmm.
But this GABA interneuron here is faulty. Why? Because the receptors over here, the NMDA receptors to which the glutamate was going supposed to
Mm-hmm.
bind are dysfunctioned. They have a
Okay.
dysfunction here, neurodevelopmental from the neurodevelopmental time. So
Okay.
they have dysfunction. Now let's say this GABA interneuron has dysfunction, so it is not going to work. So it is
Okay.
not, if this is not going to work, then glutamate, which is this is not going to deactivate this, right?
Okay. Basically, you are telling me that The deficiency or abnormality of a GABA leads to increase in the level of NMDA, and which makes a person excited. Excitation behavioral symptoms causes.
Sorry, can you repeat that?
Like basically, you are explaining me that due to the decrease or reduced level of GABA, there is an increased level of NMDA or glutamate.
Yes.
Okay.
No, not NMDA. Yes, you're right. So,
Okay.
because of decreased level of GABA, so normally what should have happened is, well, GABA was here, so there should not have been activation over here. Normally, this
Okay.
activation should not have been there because GABA was going to prevent that. See, the glutamate
Okay.
neuron is going to give glutamate, which is an excitatory neurotransmitter. When this glutamate neuron excites GABA, GABA is going to throw GABA here, and GABA is going to inhibit this neuron.
Okay.
But because GABA interneuron is non-functioning, because
Okay.
the NMDA receptor that is non-functioning here, it could not release GABA. So this neuron did not get deactivated or like inhibited, let's say. Since this neuron did
Glutamate.
not, yeah, glutamate, the neuron next to it, did not
Yes.
get disinhibited, so it remained activated. Now,
Okay.
with its activation, it went to the nucleus accumbens area, released
Okay.
glutamate onto the dopamine neuron.
Okay.
Got my point?
Okay. So after the activation of glutamate, so then what happens to to dopamine then? Sorry, I didn't
Yeah.
get it.
So it goes and connects to the dopamine neuron, which is
O-
present
Okay.
in the nucleus accumbens area here,
Okay. And then
right?
it further increases
And
the level of
yeah,
dopamine.
then it activates this neuron and increase the dopamine here.
Okay. Okay. So glutamate is also excitatory. It further increases the level of dopamine, which is also excitatory and causes the symptom worsen.
Yes, you can say that.
Oh, okay, okay. I remember with during my preparation, so I used the word glutamate candy. So I remember glutamate with the candy, it makes you happy, excitatory. So I remember from that point.
Okay. Yeah, cool. So this is how dopamine is increasing in in mesolimbic circuit. But this opposite is happening in mesocortical circuit. What is actually happening in mesocortical circuit is that we have a GABA interneuron that actually lies here. You got my point? So here we have direct connection of glutamate to the dopamine neuron. But in mesocortex, we don't have direct connection. There is a synapse which involves GABA interneuron, and then it connects to the dopamine. Now, because we have excitatory signals coming from this glutamate neuron, it not only increases the dopamine at mesolimbic circuit, but it also increases the dopamine over here. Sorry, increases the glutamate over here. Now, an increase in glutamate activates this GABA interneuron, which releases GABA and inhibits this mesocortical pathway, which releases dopamine into the prefrontal cortex, leading to decrease in dopamine in prefrontal cortex and therefore negative symptoms in schizophrenia. Got my point? Adil, Dr. Adil?
At the cortex level, it reduces the level of dopamine.
Yes, that's correct. And the reason is because of the presence of this GABA interneuron
Okay, okay.
and increase in glutamate because of the NMDA dysfunction over here. Because GABA interneuron is not working here, it is working here.
Okay, it is working at the prefrontal level.
Yes, is working
Okay,
at this level here.
okay, that's fine. Okay, then,
Yeah.
okay, go ahead.
Cool. So this is the thing that is going on here. Now,
Okay,
if we read into
yes,
this,
okay. Yeah, I took a
uh,
screenshot of that pathways, the mesocortical, mesolimbic, stratoniagral, and
This one?
tubero-enfundibular. Yes, I got a screenshot. It's a very useful diagram.
Yeah, it's fine. Yeah, that's good. It's cute.
Okay.
Okay. So we have the
Thank.
neural circuits here. So dopamine in the neural in presynaptic striatum, we have hypodopaminergia. See, this is the presynaptic. See, here, this is striatum, right? Sorry. Yeah,
Okay.
this whole area is striatum.
Okay.
So what they are saying is, in the presynaptic area of this of here we have decreased dopamine. So simple what we have already learned. So hypodopaminergia is there, which is leading to positive symptoms of schizophrenia because there is wait. There's some misunderstanding here. No.
Okay.
No. Because sorry, this is sorry hyperdopaminergia. Yeah, I'm sorry, I read it wrong. There is
Hypo.
hyperdopaminergia, which is leading to
Okay.
positive symptoms. And in the prefrontal cortex, there is hypodopaminergia, which we already
You
saw.
explain.
Yeah?
No, no, you explain it correctly, but you write it. I think there is a written mistake.
No. I've written it correctly. I'm sorry. I said, yeah, it's hyper and this is hyper.
Okay.
Yeah. I mistakenly spoke it wrong.
Okay.
Yeah, then in the glutamate, we already saw there is an NMDA receptor dysfunction on the PARV albumin positive interneuron in the downstream dopamine dysregulation, leading to downstream dopamine dysregulation. So if you see here, this is the same thing that they're saying. I told you that we have this NMDA receptor here, which is having dysfunction.
Okay.
And this is the glutamate here binding to this NMDA receptor. And this is a downstream pathway because it is coming from cortex towards the, this area, uh, which we call as thalamic area or subthalamic area, right?
Okay.
So in the
Mm-hmm.
downstream pathway, we have
Okay.
NMDA receptor dysfunction. And
Okay.
why are we calling them these interneurons and PARV albumin positive? Because with that dye, they are PARV, they are called because of this dye. They are positive with this dye, PARV albumin positive neurons. That is why.
Okay.
Yeah. And then we also have impaired cortical inhibition. This is not something we have seen or I have explained, which is leading to gamma oscillation defect. So this is not
Okay.
something, yeah, if you can see into what is gamma oscillation effect, I am not aware about this. It would be great, and we can maybe discuss it in the group chat.
Okay. Okay.
Yeah, one sec. Yeah, sorry, so sorry.
Okay.
Um, where is my screen?
Okay. So uh, we studied the neuroanatomy and neurochemistry. We are now studying the neurochemical basis of schizophrenia. This is basically the
Yes, you're right. Completely right.
neurochemical. So
Basic.
in anatomy, the cerebrum, the cortex, the temporal lobe, the striatum, the thalamus, their
So
size reduced.
yeah, so basically, if you see here, if you want to go further into that, like what is happening to these, so you can go into the neuroimaging findings. I have also attached these here, so if you want, we can go through them. Like what is
Yes,
actually happening in here?
but Palak, I which I studied it in a very easy way. Like everything is reduced in size except the lateral and third ventricle, which size increase.
Increased.
Yes, everything is
Okay.
reduced.
Okay. All right. That's even better. I will also remember it that way.
Yes, yeah, everything is reduced, and temporal lobe, and frontal lobe, and striatum and
Striatum.
thalamus. These four areas are more important.
Yes. Okay. Yeah, I'll add thalamus to that as well. Okay. Yes, then we go on to the glutamate, impaired cortical inhibition. I'll have to look into the gamma oscillation effect. I'm not really sure about that. Then we have GABA, and we also already saw that PARV, albumin positive neuron dysfunction. So what happens here is why is there a dysfunction in this? Is because of decreased expression of GAT67, that is glutamic acid decarboxylase.
Okay.
So So leading to excitatory inhibitory imbalance and impaired synchrony in neurons, and also leading to problem in working memory and sensory gating deficits. So it's like a lot of things, but again, they're
Yes.
just saying that why is this NMDA
So,
receptor dysfunction happening? Yeah.
yeah, but simple like glutamate level increased and GABA level reduced.
Yeah,
So
simple, very simple.
GABA will make you calm. It is a calmer. It will make you relax. So when the
Wow,
level
right.
is reduced, so the schizophrenic patient have like excitatory phase.
Yeah. Now, if we come here, we saw the same thing. We saw that dopamine and glutamate is actually increasing in striatum, leading to the positive symptoms, right? And
Okay.
it is decreasing. Glutamate and dopamine is decreasing, and even GABA. I don't, no, I won't say GABA, but these two are decreasing in prefrontal cortex,
Okay.
leading to, especially dopamine, leading to negative symptoms. So
Okay.
you remember this one here? Here, dopamine decreases, leading to negative symptoms. And here, dopamine increases.
Okay.
Yeah,
Okay.
yeah. What is happening with serotonin is also associated with hallucinatory phenomena. There is a receptor, 5-HT2A receptor, that is responsible for that.
5-HT2A receptor. Okay.
Yeah. Yeah. So, I mean, I studied this in neurotransmitters that 5-HT2A receptor is actually responsible for hallucinations and hallucinatory or hallucinatory behavior. So, this receptor is also implicated in the use of LSDs or, well, I say, what do you say? This what's the substance present in mushrooms? Starts with Sp.
Mhm. So what happens to serotonin level? There is abnormal level of serotonin. We can say abnormal. What word
Yeah,
we can
I would
increase
say
or reduce or abnormal?
probably increase. They will
Probably
increase.
increase.
That is why, yeah, because
Okay.
LSD is actually act on this receptor. So not really. So if they act on this receptor, they probably increase the serotonin levels, and which is
Okay.
also seen with patients of schizophrenia. So they
Okay.
have the same thing here.
Okay. But important neuro transmitters are dopamine, glutamate, and GABA, and then serotonin.
Yes, yes, that's
Okay.
correct. But this one was
Okay.
also important in terms of when we acetylcholine is important in terms of when we are going to see how schizophrenia is actually well associated with increase in substance use behavior, specifically nicotine, because
Oh, okay. Great. Okay. 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 So
Mhm. Yeah,
its importance is there, I think. Huh?
yeah, this acetylcholine is purely important there because these receptors here are implicated in schizophrenia. So muscarinic receptors M1 and M4 and nicotinic receptor alpha 7. Again, you can say that there is a hyperfunction of these receptors or dysfunction of these receptors, leading to well cognitive symptoms and which are involved in attention and concentration and processing speed. So
Okay.
cognitive.
So the level of acetylcholine is reduced.
Mm,
Hmm?
I mean, well,
You said it
you,
is hyperfunction.
yeah, I mean, we can't say like whether acetylcholine is reduced or increased, but if these receptors are not working well, let's say, so anyways, acetylcholine is not going to act, can't act on them,
Okay.
right? So let me just, okay, I have already read about the smoking part as well. But what I know
Okay.
about the smoking part right now is that these receptors, which are implicated in schizophrenia, so this one here, so nicotine
Okay.
actually directly work on alpha 7 receptor, nicotinic alpha 7
Okay.
receptor. And it also
Okay.
works on M1 and M4 receptors. And that is why people who smoke
Okay.
experience better cognition after smoking. So it is in a way, patient is trying to self-medicate because they know that there is some issue, that is some cognitive issue that is going on, and somehow smoking is helping them with this issue, because smoking is acting just opposite to what the schizophrenia is doing to them. So they're
Okay, okay,
stimulating these receptors.
okay,
Smoking, the nicotine is stimulating these receptors.
okay. Great. Okay. Then next,
Yeah. Yeah, you're right. There is decrease in acetylcholine as well.
reduce.
Yeah, reduction acetylcholine. I share this one very good graph. Just give me a second. My I am getting a call from my family. Just let
Okay,
me see. Yeah.
okay.
Yeah. Hello. Hello. हाँ पापा जी. हाँ पापा जी. हाँ 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 हाँ. ठीक है. Yeah. What I'll do is it will be very helpful for you. Let me just. Oh, someone else is. Are you Adil? Dr. Adil, Brain Health Clinic?
Yes, it's me. Yeah.
Oh, okay, okay. I'm so sorry. I thought that there was someone else also came in, and then I did not. Yeah. Let me
Yeah.
just. Yeah. I'm sharing this screen. Um,
Okay,
I'm sorry. I'm sharing this photograph on the group. It will be
okay,
very easy for you to understand what is happening
okay,
here.
okay. It's great. Yeah. Okay. So in
So you can see that we have, like, in neurobiology of schizophrenia, over this side we have a decrease in glutamate, increase in GABA, decrease in acetylcholine,
so
and
so so Dr. Falak, we studied the neuroanatomy. We studied the neurochemical basis of schizophrenia, and now we are studying what else? Neuropathology.
yeah, so we studied the I think we only studied the two things right now. We studied the
Okay.
anatomy, neurological, neural circuits, and neurochemistry. Three things, yes.
Okay.
Now we can
Yeah.
go on to, if you want, we can go on to neuroimaging findings, or we can skip it. And then, um,
Genetics. Genetics are
yeah,
also important.
yeah, yeah, yeah. Then we have this. This is neurogenetics, basically. Do you want to?
Okay.
Can we go on to this?
Multifactorial. So the etiology is multifactorial, basically.
Yes, that's correct.
The interaction of genes with environment are the main causative agents.
Yeah, one of the main genes with environment, which we say in the stress
Yeah.
diastasis
So
model.
so 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 Falak, can you read it like quickly, just like so we can study it more. So family studies are important.
Yes. Okay. Cool. So we have, like, family studies, twin studies, adoption studies.
Mm-hmm.
Then this is this one here, GWA.
Okay.
This is genome-wide association studies, and then we have copy
Okay.
number variants. So these are some of the studies and risk genes that are important. So family studies were done by Ernest Rudin in schizophrenia. Similarly, twin studies were done by Irving Gottesman. You can
Okay.
remember it with double T in Gottesman and double T in twin. So
Okay.
T twin. So family study by Ernest Rudin and twin studies by Irving Gottesman. Now,
Okay.
in family studies, it was found that
Mm-hmm.
lifetime risk of children having
Mm-hmm.
schizophrenia
Mm-hmm. Yes.
is 10% or more if if there is someone in the family who's having schizophrenia. So if you see, this
So
is the one that they that he found out. So morbidity risk, if, let's say, if a sibling is having schizophrenia, then 7.4% risk. Yes.
so if my both parents have schizophrenia, what are the chances I will have schizophrenia? How many
Uh,
chances?
Wait. It is like one parent study. I'm sure he gave. I remember reading about the
So,
two parent as
so, so,
well. But
if my both parents have schizophrenia, so the chances of me having schizophrenia is almost 45%.
okay, all
Okay,
right.
but like if I have monozygotic twin, okay,
Yeah. So
for
it's
example,
48%.
then monozygotic is almost 50%.
Yeah.
Okay, but if my brother has schizophrenia,
Mm-hmm.
and if my mother has schizophrenia, for example, if my mother has schizophrenia, or if my brother has schizophrenia, then the risk is almost same.
How much?
Like either one sibling or one parent is almost 10 to 14%, I think.
Okay. So there is like a different consensus everywhere. I don't know what to follow. So this one here, which we are seeing, this one is the Gottesman calculated. This is the, I don't know why they've written Gottesman. Probably they both did that. So morbid risk, this is like in parents they said 6%, and in siblings they said 9%, and identical twins definitely 48%.
Okay.
Yeah.
Yeah, but it just for a rough estimate, it is not very important. Like it is just remember it roughly.
Okay, so sibling and
Yes.
parent, one sibling, sibling or any parent, it is you said 10 to 14%. Although it's, I would remember nearly 10%.
Yeah, it's almost 10%, I think. I don't remember it, but almost it is the same percentage, little bit of difference, one or
Yeah.
2%. Okay,
So
just
you
for
see,
remembering, just for
yeah,
easy remembering. Okay,
yeah,
and
I
and in general population, the chance is 1%.
1%. Yeah, it's very less. All
Okay,
right. Yeah.
okay, and the incidence is how much?
Incidence is well, global incidence is 0.3%. Is it
The inci- the
0.33?
inci- the incidence is less, while the prevalence is high.
Yeah, prevalence is around 5.8%, which we studied or which I studied. Like we did epidemiology here.
Yes, incidence is less and prevalence is high, like
Yeah,
very much high. and male female ratio um, is
it's
almost same,
nearly
I think,
equal. Yeah,
equal.
yeah, yeah.
Yeah,
So you're right.
and the starting of illness in male and female is a little bit different. I think it start earlier in males, like
And
15 to
later in
25,
females. Yeah.
and later in
We
25.
can discuss the risk factors. I mean,
Okay.
you want to go into, well, let's just, we can just like do the genetics first and then come on to the risk factors.
Yes. Yeah. So in genetics, we studied the family, the 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 genes.
Yeah, the genes, right. So we did with this, and wow, we are nearly like here. That's amazing. It's
Yes.
good.
Yeah.
It's good. Like it's not that tough. Like like when I was reading it, I just found it so tough. And like, oh my God, why are there
Yeah.
so many studies?
Mysteries, yes.
So there was a Manhattan plot that was that was developed, and in Manhattan plot they found that there are maximum association number of associations with chromosome number 6. So markers are shown according to their chromosomal positions and level of association with schizophrenia. So this one over here had a maximum association with schizophrenia.
Which
So
one? So it is vulnerability gene.
the genes we'll see later, but the maximum association, if someone asks you which chromosome is associated with schizophrenia, so you have to tell them the most associations were seen with chromosome number 6. The genes we are
Okay.
going to see later. Yeah, they're coming up.
Okay.
Yeah.
So in
Uh,
genetics, what else is important?
1 second. Yeah. So we have the family studies, then we have twin studies. Let's go into the studies first, and then can we go into the like, because with this we'll come slowly, we'll come into the genes as well. Is that okay?
Okay. Okay.
Yeah. So we have twin studies, which was done by, again, Irwin Gottesman and Candler. So they told that I have made a small, this one here. The heritability is 53 to
Okay.
90%, and pairwise
Okay.
concordance is 64%. Now, what does that mean?
Okay.
So what they did was heritability, meaning that around 53 to 90% of this disease is heritable.
Okay.
And one second, let me change the color. Yeah. They said that identical twins who reared apart had pairwise a concordance of 64%. That means if the identical twins were reared apart, like monozygotic twins was reared in two different families, they still had 64% chance. So if one twin had the disease, 64% of chance of the other twin developing the disorder was there. So that was a very high concordance rate that told us that this disorder is not merely environmental, it is definitely genetic as well.
Okay. Like, the identical twins have high, like, chance of getting the illnesses compared to like both parents even.
Yeah, that's correct. Yeah. Now, you said both parents were 48% around, sorry, 45% around, but I'm not
Uh,
sure, because I have not read this. 45 is a very, very big number. like I remember, like with identical twins, that is definitely it's 48% if they are but I don't know whether it's like 45%. Please, if you can like provide from where have you read that, it would be great.
yeah, like, its percentages, so it is little bit different in every book. But like, overall, I was comparing it. So the
Okay.
ratio of, like, the both of the parents
Parents.
was less than that of identical twins.
Okay, okay. Nearly like similar to identical twins. Is that what you're saying?
Yes, yes, yes. Almost
Okay.
similar. That's, yeah.
All right. All right. So, offsprings of twins discordant for schizophrenia. That means if one twin is having schizophrenia and other twin is not having schizophrenia. So, why did this happen? When they found that 64% of the twin population, if one twin is having this, 64% was going to develop schizophrenia. What about the 36% who did not develop? Why did this happen? So, they gave two possible explanations for discordance of a heritable disorder in monozygotic twins. The first one was that the affected twin, sorry, suffers from an environmentally determined form of the disorder. So, it was either that the affected twin was carrying a gene that was that was well affected by the environment. Meaning if with the use of drugs or severe stress or whatever. And the second explanation that they gave was both twins inherited the same increased genetic liability, but that this is expressed only in the affected twin due to incomplete penetrance. So then in the next one, they say that probably the gene has an incomplete penetrance and it is completely genetic. And because of incomplete penetrance, one got expressed and in the other one, it did not get expressed. So they gave these two explanations for that.
Yes.
Yeah. I don't know. Is this important? How do you calculate like the concordance rate?
No, no,
I'm
no,
not
no, no, it's not
sure.
important. Like,
Okay.
on exam, mostly, like, the management and the clinical aspect is tested. Not so much
Okay.
this, theories. Like, these are not very important clinically for patients as well.
Okay. All right. So the next ones were adoption studies that were done. So we were like twin studies. Now, reason for conducting adoption studies, this is important, was to overcome one shortcoming of the twin method. That is, there tend to be greater similarities in the environments shared by monozygotic twins as compared to dizygotic twins. The reason being, they said that, monozygotic twins. are kind of, because they look alike, they get the same kind of dresses, they say the same kind, same school, they get the same kind of treatment. So they kind of
Okay.
have a very similar environment growing up as compared to dizygotic twins who look a little different from each other.
Okay. So they then did adoption studies.
Yeah. So assumption was that adoption does not increase the risk of developing schizophrenia and that placement is random. But it was found that children of patients with schizophrenia have at least 10% risk, children of parents with schizophrenia have at least 10% risk of developing this schizophrenia or other neuros when adopted away very soon after birth.
Like in a basic concept is of adoption studies that, like if I give my child to someone else and they raise it, but my child will have the same level of chances of schizophrenia. Uh,
Yeah,
yeah, with the other person as well
yeah. But
because
it
of
was
genes.
found, yeah, yeah. So you're saying
This is
that
the
it's
concept.
like, yeah, it's like adoption. With adoption, there is not going to be much
Yes,
difference.
it will not have much
It
effect
will
on it. Basically,
on it
it is pointing
because
toward the
we're
environment.
considering it as a genetic rather than an environmental
Yeah.
factor. But it was found that if they were given away, like and they had like a if a person has a parent of schizophrenia, then the risk of getting schizophrenia increases 10% in the sibling if they are reared by their biological parents. But if they are if they are adopted away to another parents, that risk decreases.
Okay.
Yeah. So I've written this here. Children with parents of schizophrenia have 10% risk of developing schizophrenia. Risk is similar to what is mentioned for familiar transmissions in family studies. So,
Okay.
yeah,
So in genes, we studied the twin studies, then adoption studies, and what is the
and
next
family
one?
studies. Now
Family
we are
studies.
going,
Family
so we have
studies.
a family study, like how many of them have, no, don't have, what is the morbidity risk. Then we have twin studies, we have adoption studies. Now the next one is the genome-wide association studies, where they actually now these are the genes that we are coming to. That you said that what are the genes and what are the alleles that are related or regarded in case of schizophrenia.
Okay.
Yeah. So they said that genes thought to be related to the etiology and treatment of schizophrenia are dopamine receptor genes, that is DRD2,
Okay.
glutamatergic neurotransmitters and synaptic plasticity genes, that is GRM3, GRIN2A, SRR, GRI-A1, and calcium signaling genes. These
Okay.
ones, CACNA1C, CACNA-B2, CACNA1L.
Okay.
So
Well, there is one other gene, like disc one, like
yeah,
disc
these
one.
will come under. So these are the ones that are like actually were found. This is from the CTP. What you're
Okay.
saying is, I think,
Disruption in schizophrenia or like that. Disrupted in schizophrenia, disc one. And COMT. The one other gene's name is COMT or something like that.
yeah, yeah, you're right, you're right. There's
I
one
remember
gene
writing
pumped as well. Yes, you're
Yes,
right.
I remember writing it, but I forgot the
Yeah,
names now.
yeah. So basically, GWA studies, that is genome-wide association studies, told that there are neurotransmitter genes and there are synaptic release neurotransmitter genes that
Okay.
are important here. And when we
Okay.
come to copy number variants, they said they found that there were like on 22q11.2, there was a
Okay.
deletion.
Q 11.1. This is some Dijorge syndrome or like that.
Yeah, yeah. In patients who have Dijorge syndrome, bilocardial
Mm.
cardiofacial anomaly, or Sprinzen syndrome.
Yes, yes, yes. Okay, 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 okay. You're right.
Yeah. they have like 30% increased risk of developing schizophrenia because of deletion. So copy number variant is whether there is an addition or deletion of the chromosome of 2.5 MB on chromosome this. So this is what they found.
Okay.
And this is another gene that was found that is like having a like neurexin 1. This was the recent study. Codes for a cell adhesion molecules, and there was like some deletions or some additions in this gene as well.
Okay.
Neurexin 1, which is important.
Okay.
So overall,
Which
we have like the risk genes, which you were saying were NRG, that is
yes, okay.
neureglin gene. Then we
This
have
mind
DTN.
bro. Hmm.
This is dystrobrevin binding protein 1 gene. Then we
These
have,
these are important. Palak, these are important. Okay.
yeah, disrupted
Let
in
me take
schizophrenia.
let me take a screenshot of these. Okay.
Yeah, sure, sure.
Okay. Let me. This is important. Lovely. Okay. Yeah.
Disc 1 and 2, which are neuronal migration genes, which are also disrupted in schizophrenia, and
Okay.
RGS4, which is a regulator of G protein signaling gene, which is also
Okay.
well disrupted. So there's one more thing. So how to remember this? So you see, synaptic genes are implicated. The genes that code for synapse. There are cell adhesion genes that are implicated. There are downstep regulation GP receptor genes that are implicated. So that is all. So NRG, if I remember, neuroglin we read somewhere. It's not
Okay.
here, but neuroglin
Okay.
I is responsible
Therefore,
for. Do you remember what is neuroglin is responsible for?
no, no, no. I don't remember. I just read the neuroglin, but nothing else.
All right, no worries. Yeah, it is responsible for calcium signaling. So you see, like it is
Okay.
easy to remember here. So we have
Okay.
dopamine receptor genes. There's a DTB, NP1. We have glutamate receptor genes, neurexin 1. We have calcium signaling genes, neureglin 1, neureglin cell adhesion, and downstream pathway genes, which we have already seen here. We have DT and BT. Yeah, we have covered all of these. So just
Okay.
I guess we just have to remember this. And then this one is also important. A gene that encodes zinc finger protein 80848, ZNF8048. This is also given in CTP, conceptual textbook of psychiatry.
Okay. This is what is the importance of this gene ZNF? ZNF
Uh,
encode
Not
zinc.
sure. Yeah, zinc finger protein. It encodes this
Okay.
protein here.
Okay. Okay. That's great. Yeah. It's fine.
Yeah.
Okay.
Independent replications and meta-analysis.
Yeah, no,
I'm
it's
not
fine.
sure.
It's fine. No, no, but it's fine. Little bit. We should know about everything.
Yeah. Okay. So that is it. So we have like in chromosome studies, we have
Yes.
chromosome 6 and 20q11.2. And in the genes, we have already seen the genes as well.
Okay.
Okay, I'm not sure whether these studies are important or not, but it's like
Which
are
one?
these IPSS, DOSMED? Have you heard about these studies?
No,
ISOS?
no, 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 no. These are not important. These genes. Recently, now these genes are important because now the psychiatry is going more towards like genetic side, biological side.
Hmm.
So these
Hmm.
genes are now abandoning. They don't have so much importance.
Right. Right. Okay. Cool. Yeah. So that is it. So we have another one, KT, which we'll discuss later. KT study.
So
And
okay,
yeah, and then you can,
clinical criteria. Can you
yeah,
read the
let's
clinical
go
criteria?
on to the criteria. We did not read that. Let's just go on to the criteria, and then we
I
later.
like the criteria because in most exam they ask about this criteria, that how you will diagnose schizophrenia.
Yeah, it's very. Let's go into the criteria then. So ICD-11 schizophrenia puts schizophrenia under the spectrum of disorders. There is schizophrenia and other primary psychotic disorders. Right now, they
Okay.
have divided these disorders into from 20 to 2Z. So we have schizophrenia, we have schizoaffective disorders 21, 6A22 typical disorders, 23 is acute and transient psychotic disorder, 24 is
This
delusional disorder, and then we have
this
other specified primary psychosis and schizophrenia. Yeah, what are you saying
this
something?
this is the ICD-11.
Yes, this is ICD-11 classification. I
Okay,
have
let me take
taken
a
this
screenshot.
directly like from
Okay.
the book.
Okay. Great. It's changed from ICD-10.
Yeah, it's different. It's different from ICD-10. In ICD-10, they they have a little like they have a few differences. If you want, I can help you with that as well. So in ICD-10, we have it's same. The schizophrenia is same as the same. Schizoaffective is same. Acute and transient disorder, they have like uh, with symptoms of schizophrenia and without symptoms of schizophrenia. Schizotypal is same. Delusional disorder is called as persistent delusional disorder, not delusional disorder. And yeah, there are differences in specifiers in schizophrenia as well from ICD-10 and ICD-11.
So, what is the main difference from ICD-10?
Specifiers are different.
No, no,
Um,
like
uh,
main criteria, general criteria. Same.
in main criteria, so if you say like first rank symptoms are not emphasized in ICD-11, but they are
Okay.
emphasized in ICD-10,
Yes. Yeah.
and well, if you see like um, the subtypes were different, very different. In ICD-10, they divided schizophrenia into various subtypes: paranoid, hebephrenic, catatonic, undifferentiated, post-schizophrenic, residual. But this subtype classification is not there in ICD-11. They don't decide they don't like distribute schizophrenia or subdivide schizophrenia into this because they understood
So,
that yeah,
Palak, what is the criteria in ICD-11?
we have like symptoms yeah,
General
ICD-11 is
criteria.
this. Yeah. So we have at least two of these symptoms must be present over here. If you see,
4 5 symptoms. At least one of the underlying symptoms should be
yeah. So
okay.
see, these four symptoms are core symptoms. So this include A, persistent delusion, B, persistent hallucination, C, disorganized thinking, and D, experience of influence, passivity, or control. So these are four core criterias. Now, out
Uh,
of this
so,
four,
so Palak, there is a delusion, there is a hallucination, there is a disorganized thinking and passivity phenomena. Am I right?
yeah, yeah. So out of this, I one should be there, one out of this,
One out of
and
this,
yeah, please let me complete. And then out of all of these, one should be there. So
out
two
of all of
symptoms, yeah, two symptoms total should be there, and one symptom should be from the core symptoms from A to D.
okay, one must be from A to D, and other one must be not must be should be from uh,
G.
A
So
to
we have,
F.
yeah, G. Negative symptoms, we have grossly disorganized behavior and psychomotor disturbances.
So one should be from last three.
See, what is important in one should be from A to D. That's
Okay.
important. Whether one or one more doesn't matter whether it's from A to D, whether it's from A to G. So if
Oh,
there are
okay.
persistent delusion, hallucinations, good. If there's persistent delusions and grossly disorganized behavior, then also we will consider that it is schizophrenia.
Okay. 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 Great.
Yeah.
Okay. Okay.
Yes. So
Thanks.
next on we have Longitudinal course specifiers. So we have cross-sectional course specifiers and longitudinal. So whenever we are writing the diagnosis of the patient here, we usually write we have schizophrenia. Now we write the specifier, whether it is a first episode, whether it's multiple episodes, or whether it's continuous. So if it is a first episode, we'll write first episode. So this is the longitudinal case specifier. So if it is the first episode, the multiple episodes require that there should be at least 2 episodes with 3 months of remission period. And
Okay.
continuous is there was never a remission, but course of illness should be at least 1 year. So in this, the duration is given is 1 month. So if any of these symptoms, at least two of them, are present for 1 month, then we say the patient has schizophrenia.
Okay.
And if they are present from 1 month to 1 year, whether continuously present or in a fluctuating course but never remitted, then we say schizophrenia continuous, currently
Okay.
symptomatic, right? And then if it
Okay.
is the first episode less than 1 year, but current or most, so then it is first episode. And let's say there was 3 months of remission at least between the first and second episode, then we will write schizophrenia multiple episode. And then what is the symptom status of the patient? So whether it is currently symptomatic, in partial remission, or in full remission. So this is how we
Okay.
write. So this is
How,
schizophrenia.
how,
Yeah.
do you have this ICD-11?
Yeah, this is from ICD-11.
Do you have an it in
Yeah, I
soft
do have
copy?
it. I have a soft copy. I'll share it on the group.
Oh, okay, that's great. Yeah, thank you.
Yeah. Don't worry.
Uh,
Schizophrenia, first episode, currently symptomatic. So this is how you write the diagnosis of the patient. Currently symptomatic. Let's say if the patient is currently, and this we see for the last 30 days. In partial remission, that is some clinically significant symptoms remain, but most of them are remitted. And in full remission, there are no symptoms that are remaining.
okay,
All right?
so if there are no symptoms, we will say schizophrenia in full remission.
Yeah. So we also have to specify which one, whether it's first episode in full remission, schizophrenia, multiple episodes in full remission.
Now, so
That's it.
what is this longitudinal course and cross-sectional? Longitudinal course is if we are looking at the start of the illness till the end. This is longitudinal.
Yes. And cross sectional is only for the 30 days, like whether the patient is
Okay.
symptomatic or whether not. Simple.
Okay. 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 Okay.
Yeah.
Professional. Just a snapshot at the moment.
Yes.
Okay.
Okay. Next is well six do sorry. ICD-11 also gives schizophrenia also decides schizophrenia into 6 domains. Well, predominantly, which symptoms are there? Whether it's positive symptoms, it's negative symptoms, depressive mood symptoms, manic mood symptoms, psychomotor symptoms, or cognitive symptoms. And it also tells
Okay.
us how we can rate these 6 domains. It gives symptom specified severity rating from 0 to 9, where 0 is not present, 1 is present but mild, 2 present and moderate, 3 present and severe, 9 unable to make a rating based upon available information. So,
Okay.
got it? So we have
Yeah.
positive symptoms, negative, depressive mood symptoms, manic mood symptoms. So we have 2 affective symptoms, two psycho like these, and then we have psychomotor and cognitive symptoms.
Okay.
All right. It is different from before. Like this was not given in ICD-10.
Yes. Yes. It is not given. In that there is other subtypes of schizophrenia or given like paranoid, heavy panic, simple, residual.
Yeah, right. Okay. Now moving forward, um, like so in CTP, they also give like five different kinds of symptoms domain. So symptom domain is also given for the schizophrenia and CTP, but there is a difference between ICD-11 and CTP in the sense that it says psychotic symptoms rather than positive symptoms. So this is important here. There's a difference between psychotic and positive symptoms. So if you see, again, we have ICD-11, we have positive symptoms, negative symptoms, cognitive symptoms, right?
Okay.
Then we have psychomotor symptoms and
Okay.
depressive and manic mood symptoms.
Okay.
So,
These are dominant symptoms.
yeah, so this is from ICD-11. Similarly, when we see in CTP, they give psychotic symptoms, negative symptoms, disorganization, depression and anxiety, and agitation. And
Okay.
the only thing is, what is the difference between psychotic symptoms and positive symptoms? So, psychotic symptoms only involve hallucinations and delusions, but positive symptoms involve psychotic symptoms, that is, hallucinations and delusions, but it also involves abnormal behavior of the patient and abnormal speech of the patient,
Okay.
which is actually defined in ICD 11 properly.
Okay.
Okay, next on, we can also go into like, we can go into the details of these symptoms. Yeah. So, what are the positive symptoms?
Positive symptoms.
Yeah, tell me what are the positive symptoms we already read.
Okay. Okay. So, like which I studied, like positive symptoms include delusion,
Hmm.
hallucination.
Yes.
Apart from that, formal thought disorder is also positive symptom.
Okay. Yes.
And what other thing I remember is that, like, behavioral symptoms, like, odd behavior or abnormal sexual behavior. This is also a positive symptom. Hello, 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 Palak, hello, Palak.
Hi, I'm sorry something happened to my meeting.
Oh my God, no problem, no problem.
Oops, sorry.
Okay.
Are you there,
No issue.
right? You were
Yes,
there
yeah,
all the
yeah, yeah,
time.
yeah. I was there, but you left.
Okay, okay, okay. I think I clicked on close button. I was
Oh
trying
my
to
God,
minimize
no,
my screen, but it's
no
fine.
issue,
I
no
will
issue.
just
No issue.
I
So
will
I was saying you discussing the positive symptoms, so it include delusion, hallucination, odd behavior, formal thought disorder, and one thing I'm missing more. There were five.
really because I
Yes,
remember.
delusion,
Yeah, maybe. So you
delusion,
write
hallucination,
disorganization.
disorganization.
Disorganization actually comes with the thing that you said, like formal thought disorder and behavior. So abnormal
Yes.
behavior and
Palak, in delusion, the most common delusion is of delusion of persecution.
okay,
And delusion of reference was the second most common.
okay.
And in hallucination, do you know which hallucination was the most common?
Auditory hallucinations, nearly 70%.
No, no, which auditory one? Auditory in hallucination. Which type of auditory was the most
Okay,
common? Which was
I'm
not
not sure.
diagnostic. Like
Where it
second
was,
person was the most common, but
yeah,
it was
I
not
would,
diagnostic. Okay.
all right.
And then the third person, and in formal thought disorder, mm, and odd
Oh,
behavioral
I never
behavioral
knew that
symptoms.
this was important as well. I should have. Yeah, so yes, you're right. So in mean delusions, that were the persecution was the most common. Bizarre delusion was more common in schizophrenia than other psychosis.
Yes.
And you're right. The auditory hallucination, second person, and then mean number of voices in the auditory hallucinations were three, heard
Okay.
by the person.
Third person hallucination.
No, 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 no. You're right. Like it is probably the second person hallucination, but the number of voices that they can hear, mean number of voices were three, at least three voices.
Okay.
Yeah, and what else were you saying?
Odd behavior in the sense uh, like uh, mm, like a sexual odd behavior, and one other was also very common in odd behavior.
Okay, okay. So this was the common one. You're saying that?
Yes, there were two odd behavior. I will share it with you later on. So
Sure,
that was
sure.
common. Okay.
Yeah, thank you.
And one thing was other. There were five things I read. So delusion, hallucination, odd behavior, formal thought disorder, and one thing more. I think I don't remember it at the moment. And in negative symptoms,
We have five A's in negative symptoms.
yes, but these are not that five A's of Bloller. Am I right?
No, yes, you're right. These are not five A's of Bleuler. Like
Okay,
four A's.
no, I just remember in the way that and they are little bit long sentences, like blunting of effect
Mm-hmm.
and loosening of association
Acha, okay.
and avolition or apathy
Mm-hmm.
and anhedonia.
How is it short? It is like how is it
No, no,
long? It is still
no, no.
short.
But the first two were long. So, so the first two were long, and
Oh my.
and evolution and evolution and one anhedonia
Asociality.
and
Yeah,
one other thing.
asociality. It was asociality. So we had
Yes,
like
but
five. You're right.
yeah, 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 but it was not ambivalence. At least I remember that.
Yeah. So
So
like the similar ones from the Bleuler is affective blunting and
like no, blending is also here.
alogia.
Like no, blending of effect is here, but blending of effect and is also here as well.
Yeah, yeah,
Balloon
yeah.
also has
So
blending of effect.
so we had like autistic behavior and thinking, abnormal
Yeah.
association, abnormal was it affect, and the last one which I always forget, abnormal affect, and yeah, and MB tendency,
Ambivalence, yes.
ambivalence. So
Mm-hmm.
ambivalence is not here at all. But when we say autistic behavior and thinking, we can go with asociality with that autistic behavior and thinking. Then abnormal association is not there as well. Then we have abnormal affect, which is here, and that is it. There are only two things that are like similar here, rather than
Yeah,
nothing else.
it also has anhedonia or not.
Anhedonia, abnormal affect, and abnormal association doesn't constitute anhedonia.
Okay, okay. So evolution, apathy is here. Loosening of inspiration and blending of effect is also here. And asociality is also here.
Loosening of affect is not there. Sorry, loosening of association is not here. So if you see, I have already written this here. So there are five categories of negative symptoms if you see on my screen. So we'll just
Okay.
go into these. And these are evolution, anhedonia, asociality, affective blunting, and alogia.
Yeah,
Now,
sorry, I forgot the elogia.
alogia is not like very less speech.
Yeah, elogia is mean the person has reduced speech.
Yes, right. So here, the most common ones. of the negative symptoms were avolition and anhedonia, not motivated or desired to do any work, and not able to feel any emotions. So, avolition and anhedonia were the most common negative symptoms that were found in these patients. And when they ask, like, what you can see by interview, asking them and what you can observe. So, blunting is something that we can observe, and reduced speech is something that we can observe. The rest of them are actually seen by the interview, whether they are social or not, whether, like, we have to ask them whether they are feeling emotions or not, whether they are they're having a desire to work or motivated to work or not. That is what they have
Yes,
written here.
blending of effect is also very common.
Sorry, what?
The blending of affect is also very common symptom.
Really? No,
Yeah.
I mean, it is very common in clinics, but according to the research paper, that is what, and this is suggested by Metrics Consensus
Okay.
Conference.
Okay. Maybe I read it somewhere persecutory delusion, delusion of reference,
These
and
are common.
blending of effect, and loss of insight. These four are very common.
Okay. All right. Right. Okay. So they have also written that negative symptoms have also been found to correlate with the measures of neuropathology, especially those measures of frontal lobe function or the volume of cerebral tissue. So usually this function is decreased and volume of cerebral tissue is decreased in these cases, in these patients.
Okay.
So we are done with positive symptoms, negative symptoms. Let's come on
Okay.
to the cognitive symptoms of schizophrenia.
Okay.
The cognitive symptoms of schizophrenia include these eight,
Okay.
and this is according to CTP. So these
Okay.
include immediate working memory,
Okay.
attention and vigilance, verbal
Okay.
learning and memory, visual learning and memory, reasoning
Okay.
and problem solving, speed of
Okay.
processing, social cognition, and verbal fluency.
Okay.
Yeah, I guess this is something that we have to learn.
Yeah,
um,
it's very difficult. I hate these cognitive symptoms because it's very difficult.
yeah. So,
Okay.
well, I've written a little bit about these. So I'll just, I mean, it's not here, but I've written a little bit. So I'll just say it verbally so that we can at least remember. If we have
Okay.
like a little bit of more information, we usually tend to remember things, right?
Okay.
So, in the well, immediate and working memory, we do understand that it is kind of easier to understand with immediate and working memory that they are not able to, let's say, process
But
or
little things.
do sums, for example. So, working
Okay.
memory is weak. So
Yes.
that is one. Then attention and vigilance. Under this, we have they have less attention and vigilance.
And speed of processing. If you talk to a patient, they talk after some time. Speed of processing.
Okay, yeah. So this is speed of processing. We can assess that by reaction time of the patient, I guess. So
Mm.
they will be like if the speed of processing is low. So
And
they
social
have
and social cognition is the social behavior, the social skills. Hmm?
social skills. Yes, you're right. It's social skills.
Yeah, because it is affected uh, uh, at at last at the end in dementia, social cognition.
Hmm. You're right. And then if they are not able to process very fast, even the verbal fluency is going to be decreased. They won't be able
Yeah.
to speak faster. So
Yes.
the
Yes.
verbal fluency is decreased. Reasoning and problem solving, I guess, comes down to both immediate working memory and reasoning and problem solving. Prefrontal cortex defects here, cognitive defects, and
Okay.
then we have attention and vigilance, which is like decreased attention and decreased vigilance. Um, I don't know.
Okay. No, no, it's more than enough.
Yeah. And what about
Okay.
verbal learning and memory and visual learning and memory?
Verbal learning in memory.
So yeah, I just read it. So verbal learning and memory is well, learning new information, retaining newly learned information over time, and recognizing previously presented material. So it is
Okay.
tested by this California verbal learning test. What they do is they gave the patient to listen 12 to 16 words, and then they ask them to immediately recall them.
Okay, just like verbal things.
Yeah, so if you can remember what I'm speaking right now is like verbal learning and memory. Are you
Oh,
able to learn and speak?
okay.
And similarly, they do this for visual learning and memory, which is also poor in these patients.
Okay. Maybe
They,
they give them some pictures or things like that.
yes, and they use this Wisconsin card sorting test for them in this one. And for this one, they
Okay.
use California verbal learning test scale.
Okay. Okay, that's great. Yeah.
Yeah. Okay, so reason for choosing these domains, this is important. These domains were viewed as substantially impaired, separable from one another, and to have demonstrated relationship to functional outcomes such as independent community living. I mean, basically,
Okay.
they're impacting. Yeah, if you inferred something, you can say inferred something from this. You can say that.
Okay.
Okay, okay. So we are. Oh wow, we are almost done with most of the things. So, do you want
Yeah.
to go on to the risk factors and then we go on to the management? We were discussing about the risk factors. Remember, you were saying that the so let's just have a like little bit of read here regarding the risk factors. So, can you tell me regarding the social class, like what social class is affected more in schizophrenia
You
according to the
know,
research?
like from my little bit of knowledge, previously they thought that schizophrenia were more common in a lower social class.
Yeah, that's correct.
But
I mean,
but
this
later
is
on,
not true.
they say that it is not important, and there is a theory of social drift hypothesis.
Very, very nice. The selection drift hypothesis. You're right.
Yes, and in social drift, they says that basically the patient poor condition
Is it
is due to the
the
illness.
schizophrenia?
Yes,
Yeah,
but
it's very nice.
yeah,
So,
yeah,
but it's I think it is selection drift hypothesis, or is it social drift hypothesis?
and there is one other drift as well. I don't remember.
So they give two hypotheses on that. You're right. It's environmental exposure that are more common in lower socioeconomic conditions are responsible for causing schizophrenia, lower workplace condition, inadequate nutrition, all of this. So, and the other one is you said selection drift hypothesis, illness leading to this problem, and leading to falling into the lower socioeconomic class.
One is drift hypothesis, other one is environmental factors.
Yeah, environmental factors. Yeah.
Okay,
I'm not sure what do you call that hypothesis, but they have only given like selection drift hypothesis as a name, which you already described.
okay.
Great. We have learning disability. So it was found that in people who have learning disability, schizophrenia occurs 3 times more as compared
Okay.
to the general population. But it's a
A
very
learning disability.
yeah, learning disability. But this is a very, very old data. But then again, it was applicated by Hassan in 2016. So hopefully right. And then in race and ethnicity, but now it is not. Initially, it was believed that the black population used to get more schizophrenia than the white, but it is not now. It is not true now.
No, but now important thing is, and this thing is immigrants,
Yes, yes, you were correct. Migrant
especially
population is,
the African population in UK. They have higher, prevalence.
yeah, you're right. So high rates of psychosis were seen in African Caribbean populations from the UK.
Yes, this is a little bit important.
Yeah, and this
And
is like from the study in by Morgan in 2017. This is etiology and ethnicity in schizophrenia and other psychosis. Yeah, and you're right. And it was also found that developing countries. So what they did after this. So migration did contribute to this, um, with first generation migration migrants having 2.7 percent risk, and second generation migrants having 4.5% of relative risk. Then what they did was they divided these migrants population into two, that is developed people migrating from developed countries and people migrating from developing countries. So they saw that
Mhm.
people who migrated from developing countries had more risk as compared to developed countries.
Okay.
This was about 3.3 times more risk than developed countries.
Okay.
And they also found that the black population was more at risk in migrants than than the white or other ethnicities who migrated.
Okay.
And this was about 4.8% of risk on in blacks as compared to other ethnicities.
Okay.
Yeah. And this is the study by Kento Gray, 2005.
But Palak, in social aspect, high expressed emotions are also very, like, trending.
Yeah.
They are
Yeah.
in trending.
Yeah. You're right. You're right. High expressed emotions are very important. With high
Yeah.
expressed
So,
emotions, so you're saying
mm,
that, are you saying that high expressed emotions can cause schizophrenia? But again, high expressed emotions can only cause schizophrenia if there is like a vulnerability of the patient to develop schizophrenia. That is, there's a genetic risk, right?
yes, like that is environmental, a type of environmental factors. We say that it's
Yeah.
a multifactorial illness. It basically a combination, interaction of genes with environment make a person
Yeah.
more prone. So high expressed emotions.
Okay, great. So another one is gender and age. So we already discussed that males are more prone as compared to females in like developed 5 to 10 years earlier than
Mm-hmm.
females.
Mm-hmm.
But they also say that there are other consensus who
Mm-hmm.
say that it is equally common in both males and females. But again, um,
It's equal enough.
yeah. Then we have marital status, which said that females with schizophrenia are more likely to marry than males in schizophrenia.
They have more good functioning.
I'm not sure good functioning, but they get married. They
Well,
don't say about the good functioning, but
okay,
females get married rather than
okay.
males.
Maybe they are functioning well.
Probably, and also, I don't know. Like I
Mhm.
mean, I don't know about the UK, but it is easier to hide things in females, and then like they get married off.
Yes, you're right.
Yeah, yeah. So, so family history.
Yes,
We have.
I understand it. What do you mean?
Sorry.
Yeah, I understand. Like, what are you saying?
Yeah, yeah.
Okay.
Yeah. So,
Yeah,
yeah. Now, family history, we already discussed this. And the season of birth, they say that if a person is born in winter season, they are 5 to 15% higher as a
winter
risk.
births.
Yeah, winter birth.
Okay,
Urban,
influenza,
sorry, what?
intra, prenatal influenza
Yeah,
infection.
yeah. Yeah, we're coming to that.
Okay,
Yeah. Yeah. Then we have urban versus rural place of birth. So, urban place of birth is seen at higher risk of developing. Then we have
yeah,
obstetric complications. So, if there were any obstetric complications, the patients are at increased risk of developing schizophrenia, yeah, during the delivery complications, basically. And then we have, as you said, three risk factors that increase the risk of schizophrenia: prenatal nutritional deprivation, prenatal brain injury, and prenatal influenza. These are important.
okay. Prenatal influenza deprivation, prenatal injury, and prenatal influenza. Okay,
Nutritional
okay,
deficiency. Then
okay.
the protective factors included that with a positive rearing experience, that is, if the children of schizophrenic mothers were reared by the adoption parents, they
Okay,
actually experienced a protective benefit. Even
okay,
antipsychotics have a protective benefit, and
okay.
education about the relapse prevention. With antipsychotics, it was seen that Consistent and long-term use of second-generation antipsychotics, LAIs, or clozapine in patients with schizophrenia across all stages of illness reduced the mortality risk as antipsychotics were protective compared to non-use of antipsychotics against
Okay.
mortality, including even due to cardio-cerebrovascular diseases.
Okay.
All right. Then the prognosis is based on, the poor outcomes according to NICE CKS guidelines. Well, the
Yes.
poor prognosis is if there is a longer duration of untreated psychosis, there is
Longer
early or in,
duration, early
yeah,
onset,
early onset, male sex, negative symptoms, family
divorce,
history.
alone,
Yeah,
single.
you're right. Yeah, yeah, yeah. Let's add this as well. If a person is living alone,
Yes. And
low
um,
IQ,
low,
social
like
isolation.
pre-morbid, lower IQ,
Yeah.
psychosexual adjustment or like thing like that was written. Psychosexual development, poor psychosexual adjustment or like thing like that.
Okay. I've not read that. If you can give me like what is that exactly, it would be great so that I can add it.
Okay. And one thing is insidious onset. I don't know why.
Yeah, insidious onset is also one thing.
Acute onset is good prognosis.
Yeah, it's kind of acute onset is also kind of like you're talking about probably ATPD or something. Again,
Yes,
ATPD has good prognosis as compared to schizophrenia because,
yes,
of course, it
and,
has like
and early age onset is also bad
poor
prognosis.
prognosis. Yes.
Yeah,
Yeah, we have already seen this. Like, see, early and insidious onset, low IQ, low socioeconomic status, and social isolation, past psychiatric history, continued substance misuse.
social withdrawal, Palak is also social withdrawal is also
Is it
bad
social
prognosis.
isolation and withdrawal the same
Yes,
thing?
yes, maybe same, yeah, yeah.
Okay, I don't think we're missing anything now. I think we have covered most of the things here.
No, it's all right. And what is the course of schizophrenia?
Usually insidious, fluctuating course. Sometimes it can
So,
remit, but
so
mostly it
in date,
doesn't.
in date, the famous one is Dead by Kraepelin, and the Kraepelin gave that course, which is important.
Oh, really?
Like yes, so like in that he says that 20% has acute, 20% has one episode, and after that they are fine.
Oh, yeah, 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 yeah. I read it a
Remember?
little. Yes. And then what else did he say?
And then he says that 35% people have multiple episodes, but after episode their functioning are fine.
Okay.
And then he says that and the rest 35 have multiple episodes, but their functioning is reduced, after each episode.
Okay. So 20%,
So 20, 35, and 35, so almost 90%.
can you repeat what happens to the first 20? They remit. First 20 remit. Then 35.
Yes, the 35 has multiple episodes,
Okay. And then,
but they have a static level of functioning. They are stable then.
okay. 35, right? Okay.
35, yeah.
Yeah. Next.
And then 35 have multiple episodes, but their functioning is deteriorating.
Okay.
Okay.
Yeah. Thank you.
And remaining 10%,
Mm-hmm.
and in remaining 10%, they have, like chronic. rehabilitation, like they need rehabilitation.
Okay, got it. Okay, so we have people with schizophrenia who die 20 years prematurely. Suicide contributes significantly to the increased risk of premature death, as do accidents and other natural causes.
What is the most common cause of death?
In schizophrenia,
Yes, premature death.
not sure. Is it suicide?
Due to physical illnesses, like metabolic illnesses.
Okay. Is it because of the antipsychotics or is it like
Yes,
developed?
yes, yeah. Poor, bad lifestyle and metabolic syndrome and things like that.
Oh.
Okay,
And you know,
and suicide, how much they do suicide?
as far as I remember, nearly around 5%.
Yes, 5-6%. Yeah, you're right. And
Yeah.
what are the factors which suggest that the patient of schizophrenia will be violent?
Uh,
Violence.
will be violent.
Yeah, what are the factors which in which you see, if you've seen such kind of patient, you will predict that this, it's point toward violence.
Um,
Like common people says that these are the people which do violence. You're right. Am I right? People are afraid of such kind of illness. They think that these patients are violent or they are aggressive.
yeah,
But
probably
it's not right. It is
very
not right. Very small percentage has violent behavior. So,
okay.
there are some risk factors like previous history of violence in a patient,
Okay.
or a patient which has a pathological jealousy type of presentation,
Okay.
or a patient which has a command hallucination,
Hmm.
telling him to kill a person or to kill someone,
Hmm.
and persecutory delusion.
Right.
These 4-5 things, just for your clinical practice or for some knowledge. So I read
What was
it
the second thing
previously.
you said? Previous history of violence, and then what did you
Like
say
you
next?
know, so violence. Sometimes these patients, they become violent. So the reason of violence is their past history of violence, persecutory delusion, pathological jealousy type of delusion,
Okay.
and command hallucination. Especially
Yeah.
the second person, auditory
Hmm.
hallucination. Okay, okay. So
Yeah.
people think that
Thank you.
people think that they are violent, but research shows that 14 times they are more vulnerable to violence.
Rather than doing
Yes.
violence. Yeah.
Yes, doing violence. People think that they are violent, but research shows that 14 times they are more violent. However, some patients who are violent have these type of characteristic, like command
Got it.
hallucination, previous history, or pathological jealousy, or those with persecutory delusion.
Right.
Okay.
Right. Yeah. Thank you. Okay. So
Welcome.
can we go on to discuss management in this case now?
Yes. Yeah.
Yeah. Sure. So let's go on for management. We have we have treatment algorithm for schizophrenia, and
Okay. So can you read it without seeing the notes,
oh, sure.
just for your own knowledge in a
Thank
simple
you.
way?
Sure. So when we are, this is from Maudsley, when we are talking about the first episode, schizophrenia.
Okay.
Yeah, we usually we after the diagnosis is
For example, like if you are in an interview and I'm an examiner, and if I ask you that how you will manage a patient with schizophrenia, just give me answer in 3, 4, 5 sentences, very simple, following the recent Maudsley guideline.
sure. So I would like to do some baseline investigations of this patient.
Okay.
Um, And these baseline investigations would include, taking a hemogram, lipid profile, um, diabetic profile, and
Okay.
height, weight, BMI of this person, definitely measuring the vitals, and LFTs and RFTs,
And ECG.
ECG, and
Okay.
if necessary, thyroid profile, in case I'm prescribing a drug that can affect thyroid.
Which profile? Which profile?
Thyroid profile.
Okay, okay, okay,
In
okay. So
case,
first of all, you will do the basic investigations, okay,
yeah,
and then
I'll order the baseline investigations, and
and
I would like
vital
to in vitals, and I would then start the
height,
patient on.
height and weight as well.
I have written, yeah, height, weight, and BMI. I told that.
Okay, height, weight, and BMI. Okay, okay.
Yeah.
Then
Then I would like to start the patient on, preferably on second generation antipsychotics.
uh,
It also depends. Yeah. And then up titrate the
mhm,
dose
mhm.
according to tolerance and tolerance of the patient. And
No, Dr. Palak. So you will
yeah,
start the patient with second generation, but you will not discuss this with your patient as well, or will you discuss?
I mean, yeah, I will discuss it with my patient. Do we have
Mhm.
to say that?
Mhm. Yeah, yeah. No, nice like this, nice like the patient. So nice doesn't like
Mm.
doctor.
Yeah. Anyway,
Yeah. So after discussing with my patient and taking consent from him or her, I will start him on antipsychotic medication. I think the second generation or first generation is now removed from the recent guidelines, or it's still present.
I don't. Yeah, I think it is still present.
Okay, okay. Okay. So after discussing with your patient, you will start him on antipsychotic medication, most probably second generation. Okay, then
Then I would up titrate it according to response and tolerance, and I would take it around 6 to 8
no, no, no,
weeks.
no, 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 Dr. Palay. So you will start second generation after telling the patient its usefulness, its adverse effect as well. Huh?
Yeah, side effects and stuff.
Okay,
Oh,
okay, okay,
I mean,
okay.
yeah, I mean, I'm not taking the cask exam right now, so I'm not
No,
prepared like that. So,
no, but
yeah,
this I think this is important because we forget it normally.
yeah, because our in our setting, like in our countries, it is more of a doctor centered rather than the patient centered
Okay,
consultation.
okay, and then
And then I would like to take it to the maximum tolerable dose until 6 to 8 weeks. Check the
okay,
response.
okay. You will start with the minimum dose,
Yeah, minimum dose
and
of
then
antipsychotic
okay,
to the according to response and tolerance. I would like to up titrate it and
okay,
check response. If they are responding by 6 to 8 weeks,
okay,
carry with the same.
okay,
Let's
okay,
say there is no response or minimal response.
okay,
In that case, I would switch cross taper to another antipsychotic.
okay. If there is no response, for example, after 4 to 6 weeks or 6 to 8 weeks, what is the
Yeah.
criteria?
So I would like to switch them to another antipsychotic or cross taper them. And
Okay,
it could either be second generation or first generation antipsychotic,
okay, okay,
and then again check for 6 to 8 weeks. And
okay,
when I'm doing this in the beginning itself, I'm not sure. I don't remember whether Maudsley gave this or not, but I would also start patient in the maintenance phase on
okay.
CBT for psychosis to build
What is CBT?
insight. There is a cognitive behavioral therapy for psychosis, which involves a lot of things. One of them is to building insight and understanding, and making them aware about their illness, the delusions and hallucinations that they're having, and to
Okay.
yeah.
Okay.
So I
Okay.
would like to do that as well. And then after six, and if there is no response, change the antipsychotic medications. Again, follow for 6 to 8 weeks according to the response and tolerance. Slowly up titrate it to the maximum tolerable dose according to
Okay.
response. And
Okay.
if it is good, then follow the same thing. But if it is not good, let's say if they do not respond, then I would put them in the category of uh, treatment resistant schizophrenia, and I would like
Okay.
to start them on. Well, this is according to the guidelines. Um,
Okay. And meanwhile, you will also look for the compliance and
yes, well, it
to check
depends.
whether
Yeah,
patient is taking medicine or not.
yeah. Compliance is important here. Should not be pseudo compliance. If patient is not compliant, then can't start on clozapine. If patient is compliant and still not responding, then yes, we can consider it as treatment resistant schizophrenia. And how much reduction in symptoms was there? Was the reduction in symptoms more than 20% or less than 20%? Because if it is less than 20, more than 20%, we can still wait or add some adjunctive therapies and agents.
Okay.
Yeah. Uh, there's a role of ECT as well here. ECT, I would
Yes.
like
Yeah.
to, I would prefer if I need an um, immediate, immediate control on the situation. For example, if the patient is very
Yes.
violent.
Yeah, but like in first episode psychosis, they also the nice mention that after the patient will come to you after like 4 to 6 weeks, you will check their vitals again, and
Oh, yes.
yes,
Yes.
and apart from that, you will always try to start one medicine. You should try to avoid polypharmacy. You should not give two antipsychotic at the same time, only when needed or at the time of switching.
Yeah. Yeah.
And apart from that, what else is important in first episode psychosis?
Ensuring the compliance, at least,
Ensuring the compliance.
and I guess you're right. Like metabolic syndrome, to check onto metabolic syndrome just in case they are like, and weight loss, whether weight gain is there, so we'll look into that as well.
Yeah.
Advise them some lifestyle changes because with medications there is a high possibility that they will gain more weight. So,
Yes. Yeah. Right. Yeah.
and
You're right. Yeah.
all of this, like every 3 months, the check on this stuff, the BMI every month, and every 3 months we can do the lipid profile and diabetic profile of the patient.
BMI every month.
Every visit, we usually do it every month,
Okay. In UK.
but UK, I think it is every month only, I guess. Is it
Okay.
every 3 months? I'm not sure.
Okay. Okay.
Yeah.
No, that's fine.
So they have here monitor and record the following regularly and systematically throughout
Okay.
treatment, but especially during titration.
Okay.
So wait weekly for the first 6 weeks, then 12 weeks, 1 year, and annually. See, weekly for the first 6 weeks, then at 12 weeks, 1 year, and then annually.
It is in Maudsley.
Yeah, it's in Maudsley. This is nice CK guidelines in Maudsley. This is according
Okay.
to
So
NICE guidelines, a summary.
okay. So wait every month.
No, every week for the first 6 weeks.
Okay, every week for the first 6 weeks.
And then after first 6 weeks at 12 weeks,
Okay,
and then
after
at
that,
one
there is
year,
12
and
weeks.
then then annually.
And after 12 weeks, then how much?
1 year. Can you see my screen? It's written here.
Okay.
1 year, and then annually.
Okay.
Like, are you able to see my screen or is it switched off?
No, no, no. I'm seeing. Yeah.
Oh, okay. So if you see here, we are when we are talking about UK NICE guidelines, last reviewed on
Okay.
September 2024. First episode psychosis for people with newly diagnosed schizophrenia. Offer them oral antipsychotic medication as well as psychological intervention. So this is CBT or family therapy, family intervention.
For
We
people
have to
with new
provide.
schizophrenia, after offer oral antipsychotics,
Sorry.
offer oral antipsychotics along with psychological intervention. So in
Yes,
psychological
yes.
intervention, what we will do, Palak?
So we have like a few things that we do in psychological intervention. So
Mm-hmm.
as I already told you, we build insight, we build awareness in the
Mm-hmm.
patient. Well, there are like 4, 5 things.
Mm-hmm.
If you remember both guidelines, have you wait, CBT and psychosis have two models. Have you heard about this model of cognitive model of psychosis and Morrison cognitive model and Garrett's cognitive model?
Mm-hmm. Mm-hmm. Okay, so it also include like your psychological intervention. It also include building a rapport with the patient, uh, become also do become showing empathy and listening to him, addressing his concerns. Um,
Well,
you know,
it's not just that. I think it is more about
yes,
bringing
yes,
awareness that
yes, you are right. That is the more specialized one, like CBT and
yeah, CBT for psychosis, like it is like properly like there is like 4 or 5 things that are involved in that CBT of for psychosis.
yeah,
So
for delusion, they do some specific. But yeah,
it's
you're
like
right.
4 to 9 months in duration. And
Oh,
what do they do is they include the collaborative identification of target problems or symptoms and the development of specific cognitive and behavioral strategies to cope with these problems or symptoms.
okay, okay. Okay, so for a first episode psychosis, offer oral antipsychotic medications along with psychological intervention.
Yes.
This
And
is
as
which
you said,
edition? This is which edition of Morsley?
this is 15th
Morsley?
edition. No, this is
And
15.
okay, 15. Okay.
Yeah,
This is
yeah. This is
yeah.
15th edition.
Okay, okay,
Yeah, as you said also, it says provide information and discuss the benefits and adverse effects profile of each drug with the service user. You already mentioned that.
okay. Discuss the usefulness, adverse effect, and things like that
Yeah.
with the patient. Okay.
Yeah. So before starting antipsychotic medication, undertake a thorough assessment of physical health and offer an ECG specified in the summary of product characteristics or clinically indicated.
ECG is important. Okay, and thorough assessment of physical checks, vitals,
Yeah.
and ECG. Okay.
Yeah. Then recording of indication.
No,
Treatment with antipsychotic
no, no,
medication
no.
should be yeah.
Farah, can you read the second sentence at the top?
This one.
No, no, no. The choice of drug.
The choice of yeah, they have said they're just saying that
I
the
I I,
choice of
li- I,
drug
li-
should be made
I like this sentence.
by the service user and healthcare professional together, considering what are the potential side effects of the drug, that is extrapyramidal side effects, what are the cardiovascular adverse effects, metabolic adverse effects, and other adverse effects, including hormonal adverse effects. So we have to tell all of these effects, adverse effects, and then we have to ask them, and then we make a choice of the drug. The views of the
And
carer where the service user agrees.
have the choice of drug is second generation or is not mentioned.
No, 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 it's not mentioned. No, NICE does not mention anything. Okay, I have to be clear here. Okay, NICE does not even mention the name of the medication. The problem is this: NICE only
Okay.
mention oral antipsychotics. The name of the medication or the choice of medication is something that we go on with with Maudsley. Now, if you see here, Maudsley tells us in the first episode, psychosis or schizophrenia, there is start with second generation antipsychotic, or agree with the choice of antipsychotic medication with the patient.
Okay, for example, if the patient says that he was well with the haloperidol, then we can start haloperidol. But if he or she doesn't specify it, then the doctor should start with second generation.
Yes.
Okay,
Sorry, it's minimum effective dose. I said wrong. So we have to
you're
titrate it
right.
until the minimum effective dose
No,
and
no, you are right.
adjust.
You are right that we can start with minimum effective dose and we can titrate it to according to response.
Yeah, dosage regimen according to therapeutic response and tolerability. And then we
Okay.
assess over 2 to 3 weeks. So if it is effective, I did not know it's 2 3 weeks. I thought it's no, actually it is 6 to 8 weeks. It is not 2 to 3 weeks. But fine. Continue at the dose established as effective
Continue it.
and no effect, change drug and follow above process. Not tolerated or poor medication adherence. If poor adherence related to poor tolerability, discuss with patient and change to drug with more favorable adverse effect profile. When efficacy and tolerability established, switch to long acting injection. So basically, they always say to switch to long acting injection later.
When, when, when.
Then continue. And then if it is still not effective, then switch to clozapine.
Okay,
Yeah. Then they also tell us like what to do if there is acute exacerbation of schizophrenia and you found that they are fully adherent, that compliance is not an issue. They were
okay.
compliant and still there is an acute exacerbation. In that, first we have to investigate what could be the causes of that. Was it because of some social or psychological precipitant? That means a
No,
stressor.
you told that in the first, at the start that therapy, you use the word therapy. So here, the importance of therapy is here.
I mean, in the acute exacerbation, Maudsley, okay, and Maudsley actually does not say like you have to give the therapy.
Okay,
Maudsley says that you can give the therapy and it is helpful, but NICE emphasizes on therapy. This is important. NICE guidelines emphasize on therapy here, psychological intervention, but Maudsley does
okay,
not say that.
okay. So that diagram is not from nice. This is more the one.
Maudsley actually compiled the NICE guidelines here.
Okay.
This is a summary of NICE guidelines of mods
So
from
okay.
which
So
are
Palak, if a patient has acute symptoms and compliance is okay, then what we will do then?
in that case, first investigate what was the reason. Second, provide appropriate support. Yeah, you said therapy, and continue use usual drug treatment. So basically, they say you can add a short-term sedative, benzodiazepine, or any sedative, or you can switch to a different or more acceptable antipsychotic medication and
Okay.
discuss this with the patient and then give it over for 6 to 8 weeks. So either give short-term sedative or switch the antipsychotic.
Okay. For example, if a patient is on risperidone 4 milligram and patient became aggressive, then better to add some benzodiazepine or if needed, change it to olanzapine.
Yeah, I would. Yeah, I mean, prefer benzodiazepine addition rather than changing it. But
Okay. If the second antipsychotic also not working, then switch it to
then
clozapine.
clozapine.
Okay.
Yeah.
Okay. This
So
diagram is very important. Okay.
okay. Yeah. There's one more thing here. You were right. So see here they have written provide appropriate support and or therapy though. It's like it's not necessary, but yes, if it is you think that it is necessary because of the stressor this has precipitated, then we should provide therapy to the patient.
Yes,
And
if the patient is unwell on risperidone and he has some issues at home, then discuss with psychologist and she can do therapy.
yes, that's correct. The next one is if, yeah, the next one is, let's say, relapse is happening or acute exacerbation, but adherence we don't know, or it is poor. If there is a poor adherence or adherence is not known, in that case, what we should do? That is
So,
given here.
so if we don't, if the adherence is poor, then we will see that why it is poor. Like if it is due to the adverse effect of medication, so then change it to a medicine which has least adverse effect. Or
Yeah,
if you think that the adverse effect is due to the patient problems, like illness, like grandiosity or psychotic features, then better to give a depot injection.
yeah,
And if you think that the compliance um, is due to some cognitive impairment, then give simple dose.
yeah, yeah.
Hmm?
And if you think that compliance is issue is because of forgetfulness or patient is disorganized, we can consider, yeah, as you said, we can simplify the drug regimen, and we should reduce anticholinergic load because it will further decrease the cognitive cognition in the patient. And also we consider the compliance aids, for example, I don't know, alarms or phone calls, whatever it is, and consider depot LI as well, again, last thing.
Yeah. But if the patient compliance is fine, if the patient compliance is fine, look for the stressor, discuss with psychologist, add short-acting benzodiazepine. If it's working okay, otherwise switch to other antipsychotic. If it's working okay, if not working, start clozapine.
Yeah, after 8 weeks,
Okay.
6 to 8 weeks. So there's one thing here written, if you see here, when there is prior treatment failure but not confirmed treatment refractoriness, olanzapine or risperidone may be better options than quetiapine. Olanzapine, because of the wealth of evidence suggesting slight superiority over other antipsychotics, should probably be tried before clozapine unless contraindicated. So basically, when you are switching to the antipsychotic here, and you have already not already tried olanzapine, they are saying try olanzapine before switching to clozapine. And they also say that one RCT told them continuing with amisulpride was as effective as switching to
No,
olanzapine.
no, 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 but don't confuse yourself so much. So this,
Okay, okay,
these are the important things because otherwise we will remember nothing.
okay,
It's
okay.
fine. Okay.
Yeah,
Then
that is
what else?
it.
Mm-hmm.
Now we have a few drugs here. Quick
So,
reference
so,
for.
so you are starting as a treating psychiatrist. You are starting medicine. So, what you will do for first episode?
I'll definitely. I'll. Yeah. See, I'm not gonna go into the C like cask thing. I'll just
No, no,
say
no,
like.
no, no, no. Just it's just in what you read is not casting. So you will discuss. First of all, you will do basic investigations and ECG and vitals, height, weight, and BMI, and then you will discuss the choice of antipsychotic medication with the patient. You will inform the patient about its usefulness, its adverse effect, and mechanism of action. Then you will start the medicine, maybe first generation or second generation, at the minimum effective dose, and then you will see the patient after 2 to 3 weeks. You will see the response to medicine. If the patient is improving, you can increase the dose of medicine. If the patient is not, if the medicine is not working, then you can switch to the other medicine. You will give oral medicine and will always try to give one medicine at a time.
Yeah,
If it is
that's right.
not working, if it is not working, then you can switch to other medicine. If it's still not working, then you will start clozapine. It's also written in nice guideline for first episode psychosis. They mention about clozapine.
Okay. Okay. So let's just read this here, and let's just read it a little faster. Um, so monitor and record. This is important. Monitor. Yeah. Monitor and record the following regularly and systematically throughout treatment, but especially during titration. So, what they say is efficacy, including changes in symptoms and behavior, adverse effects of treatment, taking into account overlap between certain adverse effects and clinical features of schizophrenia.
Okay.
Example overlap between akathisia, agitation, or anxiety. Adherence is important and wait weekly for the first 6 weeks, then 12 weeks, 1 year, and then annually. Waist circumference to be taken annually. Pulse blood pressure at 12 weeks, 1 year, and annually. Fasting blood glucose, HbA1c, blood lipids at 12 weeks, that is 3 months, 1 year, and annually. Nutritional status, diet, and physical activity. Not written any, they have not written anything, but they say that just do it regularly. And physical monitoring is to be the responsibility of, yeah, this is okay, this is fine. This is also important. Do not use the loading dose of antipsychotic medication because that does not apply to depot forms. It does not apply to depot forms, but it applies to normally loading dose you don't have to give. Otherwise, patient will end up into EPS or acute dystonia. We don't want that.
Okay. You low dose.
Yeah, we start with the low dose, minimum effective dose, and then we titrate it upwards.
Okay. It's
Yeah.
fine. Yeah.
If there are subsequent episodes, so we already discussed about the first episode.
Yes.
According to
Yes.
NICE, if there are subsequent episodes and maintenance treatment or maintenance treatment, then we consider the clinical response and adverse effects of the patient current and previous medications. So we check out the
Yes.
past history of medications and what were the clinical response and effects on that,
Yes.
and then
For
consider
maintenance dose,
offering.
NICE says that it's better to give the medicine which was working for the patient, like in acute episode.
I mean, it says for the first episode as well, same thing.
Yes, like in first episode, the medicine which was working, try to continue those medicine as well. It's
Yeah.
yeah.
To people with consider offering depot or LAI antipsychotic to people with schizophrenia who would
Yes.
prefer such treatment after an acute episode and known to be non adherent to oral treatment or who prefer this method of administration.
Yes.
Simple.
Yeah. Yeah. Simple.
Simple.
Yes, yeah.
Then GPs and other primary should monitor the physical health of the patient. We have already seen this, how to monitor it and what are the things to do. 6 weeks, 12 weeks, 12 weeks, 1 year annually. Then one more thing here. Okay. Yeah, we have already. So they say carry out a trial medication at optimum dosage for at least 4 to 6 weeks.
Okay.
Yeah. Although half of this period is probably sufficient if no effect is seen at all.
Mm-hmm.
Yeah. But which is 4 to 6 weeks is the one. So because when we are reading into when we go into the like treatment resistant schizophrenia, they say that
Mm-hmm.
6 weeks is the minimum time period that you should have used an antipsychotic up to its maximum effective dose, that is the tolerable dose, in the patient.
Like for first episode, they give the time duration of 2 to 3 weeks.
Yeah, but it is, see, I mean, I would, that is according to Maudsley. But when we are talking about the treatment resistant schizophrenia, we don't go with
Yes,
2 to 3 weeks.
yes,
Two to three weeks
but
is
for
not the
clozapine, they
right
give
time.
more duration. They say that
Yeah,
for clozapine, give at least 6 weeks.
yes.
Okay,
Correct. Okay,
you're
so
right.
quick reference for licensed maximum doses. This is from European Medicine Agency of January 2025. So this is the one. So we have chlorpromazine, minimum 200 to maximum 1000,
Mm-hmm.
haloperidol 2 to 20,
Mm-hmm.
trifluperazine 10 to 20,
Mm-hmm.
amisulpride 300 to 1200, arip
Mm-hmm.
10 to 30,
Mm-hmm.
acenapine 5 to 20, cariprazine 1.5 to 6 milligram per day, clozapine
Okay.
from from 100 to 900,
Mm-hmm.
lurasidone 40 to 160,
Mm-hmm.
olanzapine 5 to 20,
Mm-hmm.
quetiapine
Mm-hmm.
150 to 750, and
Okay.
risperidone 2 milligram to 16 milligram per day. We just have to remember the minimum and maximum doses of these medications. And so this is also important. In the recent 5 years findings, it was found that for negative symptoms, these are the antipsychotics that were very helpful. What are these
Okay.
antipsychotics? These were amisulpride, cariprazine, aripiprazole, clozapine, and
Mm-hmm.
roluperidone.
Mm. Okay.
So very important. Amisulpride, cariprazine, aripiprazole, clozapine, and roluperidone. In our
Mm-hmm.
clinical setting, we do use amisulpride and aripiprazole. Um, I have not seen using too much of cariprazine or clozapine. Roluperidone, I have never seen. And then when if we have to give antidepressants in the negative symptoms, let's say, so when do we give this? We give this if there are negative symptoms in the patient, but depressive symptoms predominate. So we add an SNRI or an SSRI in these patients.
Okay.
Yeah. In somatic therapies, we also give somatic therapies to these patients. This
Mm-hmm.
includes transcranial brain stimulation, that
Mm-hmm.
using intermittent theta burst stimulation. Um, and it is given on the left dorsolateral prefrontal cortex.
Okay.
And as you asked me, like, what are the psychotherapies? So we have CBT is a psychotherapy, and we also have
Mm-hmm.
rehabilitation measures,
Mm-hmm.
which include cognitive remediation, social
Mm-hmm.
skill training, and
Mm-hmm.
exercises.
Social skill training
Yeah, and
in social
exercise.
management. In social management.
Yeah, in social management, in rehabilitation measures. Then we have
Oh,
some other medications that are also useful. This is N-acetylcysteine. Yeah, that's it. This is like a summary of the things. All right, let's go forward.
okay.
In Maudsley, they also say that
Mm-hmm.
um, so if so, let's say this is like here, switch to clozapine, and clozapine
Okay.
is not working. Like
Okay.
there is an inadequate response to this. Then it says that you can augment the clozapine with modified ECT.
Okay. Okay. Okay.
Yeah, in treatment
Okay.
resistant schizophrenia. That's what it says.
Okay.
Yeah. Next on, let's go to the treatment resistant schizophrenia. And do you want to discuss Kane's criteria or directly like the TRIPS, that is treatment response and resistance in psychosis, that was given
Mm-hmm.
by Howes? So this is the most recent criteria. Kane's criteria is a little older one. Kane's criteria, it says that well, at least 5 years of poor functioning was is present in the patient with three. This
Okay.
is a historical poor, like old criteria with two.
So. Mm-hmm.
Yeah, with
This
three
is
treatments with antipsychotic medications, with two
okay.
different classes of antipsychotics. and an equivalent of around 1000 milligram of chlorpromazine, and at least for 6 weeks. So if you see here, they
Mm-hmm.
say there is no period of good functioning for 5 years, at least three treatments with antipsychotics of at least two different chemical classes,
Mm-hmm.
and 1000 milligram of chlorpromazine with for a duration of 6 weeks.
Mm-hmm.
This is historical criteria, and current criteria is that when you take the BPRS score, that is brief psychiatric rating score, of which the total score of which is 45, um,
Mm-hmm.
BPRS score should be more than or equal to 4 on following two items out of 4. What are these
Mm-hmm.
two items? Like, what are these 4 items? Conceptual disorganization, unusual thought content, suspiciousness, and hallucinatory behavior. So, the minimum requirement is you have to have at least two scores out of 4 in either of these two, and a total score of 45 in BPRS. So in
BPS.
BPRS scale, more than 45 total scores should be there. And out of these four, that is conceptual disorganization, unusual thoughts, hallucinatory behavior, and suspiciousness, in at least two domains, you should score 2 out of 4.
Two
This
out
is,
of four.
yeah,
2 out of 4. So how many scores? How much score this BPRS has?
more than, I'm not sure how much it is, but I think you have to score more than 45 on that. Total scores, I'm not sure for the BPRS scale. We don't
But
usually
how-
use BPRS.
for like among these four, how many should be present?
See, we when we score something, we have this thing now, like
Uh,
1, 2, 3, like on a
okay.
scale of 4, how much conceptual disorganization is present. So at least 2 by 4 should be present in any of these two, in two of these four.
Okay.
So,
But total score must be above 45.
and total score must be above 45. So either two
Okay.
of four this,
Acceptable.
and then we have one of four this, one of four this. This is two of
Okay.
four. So at least suspiciousness in this has got two scores, and total score of BPRS in other questions, including other questions, is 45. We can also use the other one, that is CGI, that is clinical global impression, and in this the score should be more than or equal to 4. This is what Kane's criteria say. It also mentions it also mentions that if after 5 weeks of treatment with haloperidol up to 60 milligram per day, like, or any dose that is equal to haloperidol that is up to 60 milligram, like if you're using any antipsychotic equivalent to 60 milligram per day of haloperidol, at least given for 6 weeks, there is failure to reduce the BPRS score by more than 20%, or the BPRS score is still more than 35, or CGI score is still more than 3, then it will be considered as treatment resistant schizophrenia. Do you get my point? We have to remember most of this. Dr. Adil? Hello?
Sorry, my charge
Yeah,
is finished. Sorry.
it's okay, it's okay. I spoke so much. I did not know you are not here. All right. Wow, you're still here. That's amazing. Did you get what I said here in the prospective thing or not? Dr. Adil? Dr. Adil? Dr. Adil? All right, let's finish this. So we have, so this is what is modified with Keynes criteria. Now, what is modified Keynes criteria? So in modified Keynes criteria, everything is same except chlorpromazine, equivalent change to 400 to 600. So basically, chlorpromazine equivalent over here was 1000 milligram, but it is changed to 400 to 600 in the modified Keynes criteria, right? So when we look into the modified Keynes criteria, we look as a historical basis, 5 years of continuous illness or with poor functioning. Then we had 3 treatments with at least 2 antipsychotic medications with 2 different chemical classes for at least 6 weeks of an equivalent of chlorpromazine of 1000 milligram, right? And now when you are looking at that, you will see BPRS score of patient more than 45 with 2 out of 4 in either of these 2 domains out of 4, that is conceptual disorganization, unusual thoughts, behavior, suspiciousness. So formal thought disorder. So unusual thoughts, suspiciousness, disorganization, conceptual disorganization, and a hallucinatory behavior.
Mm-hmm.
Are you here?
Yes, yeah.
Okay. So yeah, and then there is one more thing. Prospectively, we see, I don't know if you heard this or not, that prospectively we see that um, well, BPRS score is not reduced more than 35 and or more than 20%. And CGI score is not reduced more than 3. So in
Okay.
these cases, we say that even after, well, 6 to 8 weeks of proper treatment with a haloperidol dose with of equivalent like
Mm-hmm.
any medication of any antipsychotic with an equivalent dose of 60 milligram of haloperidol was given for a good duration of time, and still the BPRS score did not reduce more than 35 or more than 20%, or CGI score did not reduce more than 3. That means this is a treatment resistant case of schizophrenia. This is what Kane said. So if you see no improvement after 6 weeks of treatment with haloperidol up to 60 milligram or any other equivalent dose of any psychotic up to 60 milligram of haloperidol and there for 6 weeks. They also added persistent positive psychotic symptoms despite adequate drug therapy as an essential criteria. Apart from this,
Okay.
so this was Keynes criteria. However, it got modified. So if you see, this is the modified Keynes criteria. In modified Keynes criteria, everything is same except for the dose of the chlorpromazine. So they reduced the dose of chlorpromazine to 400 to 600 milligram in modified
Okay.
Keynes criteria, and everything remains
Yes.
the same.
Okay.
Yeah. Now there is a
Mhm.
little modern criteria that has come up. So this one is now preferred than the other one. 1 second.
Okay.
I'm sorry, what is happening? Trying to remove this.
Mm-hmm.
Yeah. So this is treatment. This is called as TRIPS. Treatment response and resistant in psychosis.
Mm-hmm.
TRR in psychosis. TRIP. Treatment response and resistance in psychosis. And this is the criteria that is now used in most
Okay.
of the places, in most of the clinical settings, in most of the places. This criteria was given by Hobbs et al. In 2017. And it says that it is very simple criteria. It says that, well, I'll just write it here. Duration of 6 weeks of at least
Mm-hmm.
two
Mm-hmm.
antipsychotics.
Okay.
It does not mention first generation or second generation. No specification about that. It says two
Mm-hmm.
antipsychotics for 6 weeks, minimum 6 weeks
Mm-hmm.
each. So that means for 12 weeks, you have at least given two antipsychotics, right? And then it says
Mm-hmm.
um, scales. In any of these four scales, whether it's BPRS, it is Essence, it is SEPS,
Mm-hmm.
or PENS. In any of these four scales, there is
Mm-hmm.
decrease of less than 20% of symptoms from the baseline.
Mm-hmm.
And then it also mentions with
Mm-hmm.
an 80% of adherence, um, adherence was, what do you say? Like it was 80% adherence completely was there. And adherence should be checked by three things: chart, clinical, like the drug charts, by the patient's attender, and by the strips. So any of these two should be used to check the adherence. That means the compliance of the patient, any two of these.
Mm-hmm.
And yeah, and then also says that the quality of life and functioning in using, there are two scales, I only remember one, SOFAS. Using a scale called
Mm-hmm.
SOFAS should be used,
Okay.
and there is s- not much improvement on this. So this is there are like two things. This is optimum, like this is minimum and optimum. This is minimum criteria, and this is
Okay.
optimum criteria. And these antipsychotics should be given at least for the dose of 6, which is equivalent to 600 milligram of chlorpromazine.
Okay.
And in the optimum criteria, this is same. Um, This in this they have added two things. They have added that one, that adherence should be checked using serum levels of antipsychotic drug 1 week at least after starting, and then on the subsequent week. We will see like exactly. This is what they said. And it also says about long acting injectable. So at least you have given long acting injectable for 4 months so that the blood serum levels have reached to um, the steady state. This will ensure compliance. This is optimum criteria. So yeah, let's check. Like, have I missed anything? So duration is more than equal to 6 weeks in a therapeutic dose. Similarly, duration of more than 6 weeks in the therapeutic dose. Then equivalent to more than equal to 600 milligram of chlorpromazine, right?
Mhm.
Then more than equal to two past adequate treatment episodes with different antipsychotic drugs, right? Now here also it says more than equal to two past adequate treatment episodes with different antipsychotic drugs and at least one utilization of long acting injectable for at least 4 months. So this is an addition here,
Okay.
right? In the optimum criteria for treatment resistant schizophrenia.
Okay.
Yeah. The next is more than equal to 80% of prescribed doses were taken, and adherence should be assessed using at least two sources: your pill counts, dispensing chart reviews, or patient or caregiver report. So,
Mhm.
either of these two. And here they have added that this too, it is important, but with the addition of true antipsychotic serum levels measured at least at two occasions, which are separated by at least 2 weeks, without prior notification of patient. So this is
Okay.
important. So we have seen this. So these are only two things that have been there in the optimum criteria. Other than that, everything is same in the optimum or minimum criteria. So these are the two things that have been added in the optimum. So basically, have they not written about this BPRS? They have not. It's not mentioned here, but I read it that in either of these scales, BPRS, SENS, SEPS, or PENS, there is not more than 20% improvement. That means less than 20% symptoms improvement from baseline is there. And SOFAS was also given. I read the paper of this one here, this one, this guy, the same paper, and that is how I came to the conclusion of this.
Okay.
Yeah. So this is strips. That's it.
Great.
Anything else?
That's fine. Yeah, it's so much, but like
Oh
you'll
my
be so
God.
much tired. You'll be so much tired. You studied so much. It's not easy.
Thank you so much. I mean,
Yeah.
I'm doing it like for myself as well, so that I have like prepared notes, and if it helps, of course, like why
No, no,
not?
no, no. The way of your presentation and teaching is excellent. So
Thank
most of the thing
you.
now I remember by heart even.
That is awesome. I think that is the thing that is important because now when we solve questions, we at least we at least will remember these things now. So even I will remember it. So I think that is the best thing.
No, the way you taught me, it is not easy, but like you prepared it so well that you have such a good command on it. So you presented it in a very easy way. Otherwise, it is very difficult topic. It is not easy. So
Yeah.
yeah. So then we will discuss some other topic. But for the time being, I think it is very good effort. It was not easy. and at
Thank
one,
you.
yeah. So then next time we will discuss some other topic.
Yeah, what I will do is you said that you are not familiar about the CBT psychosis model, right? So what we can do is, like maybe maybe I'll share some notes of mine on CBT psychosis, or maybe I'll upload a small snippet of that, or
Yes,
we can discuss like I don't know, like
yes,
because see, if this was a very long video, so
yes,
so let's say sorry, this was a very long session. So
yes,
what
yes.
we can
Totally.
do,
But you basically you made it easy by like contracting the things and explaining the things in a simple way. Otherwise, it is very difficult to do all these things in a one go.
yeah, it's true. Thank you.
Yeah.
It means a lot. Actually, it does because you see, even like we all are learning. So and it gives me more to do. Like if you say this, then I'll do it more. So
No,
it will be
no, you
like
are right. Yeah,
yeah.
it is very effective, and like we can add like little bit more to the management, like more to their part. We should also do in more little bit more detail next time.
Yeah, I did have more of the management part, like in terms of but I saw in like MRC Psych thing that
Hmm.
they did not ask a lot of questions regarding the first episode or something. But maybe we can actually do the clozapine part because dosing of clozapine, side effect of clozapine, ANC monitoring, and
Yeah, they like it. They like it. They like it.
augmentation. Yeah, this is very, very important. So what we'll do is we can take the clozapine part, I think, and it will just finish in 30 minutes or at max 1 hour. So I don't
Yes,
think
yeah.
it's a
We,
big
we,
one.
we, we will take one. You will take one class on this clozapine.
Okay, I'll do a class on clozapine then.
Yes, and Palak, I need that DSM 4 or DSM 11. If you
ICD
have
11.
that, ICD 11. Yes, ICD
Yeah, yeah, yeah.
11.
I'll share the soft copy of that with you.
That will be great. I will read that schizophrenia part again to see
Yeah.
that you already explained it very easy way. I took some screenshots of that part, but
Great.
I will study it myself as well to better memorize it more.
Yeah, great. So I'm
Uh,
sorry.